Technical team, after some time, I will log in from my another device. So I will leave for some time for 1 or 2 minutes and then log in from my phone. Right now, I am logged in from my Mac. After 1 hour or so, I will log in from my mobile.
Okay, ma'am.
Yeah.
Ma'am, we are starting session, ma'am. We are on live.
Okay.
So good evening, doctors. I am Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the next webinar organized by this Surat Obstetrics and Gynecological Society in association with Navsari, Vapi, Valsad and Baroj OG Society. So I would like to welcome the audience, chief guest and guest of honors and the chairperson speakers of today's session. I would like to welcome the Master of Ceremony, Dr. Kavita Shah, ma'am. Madam has done her MS OG and Madam has received various awards and credits during her academics. And Madam is associated with Kavita Hospital and Star Hospital, Ring Road, Surat. With this short introduction, I welcome you, ma'am. I'm handing session to you for further proceedings, ma'am.
Thank you, Stalin. Good afternoon, everyone. We will be now. We are ready now for a very exciting webinar on mixed bag that is organized by SOGS along with Vapi, Bharuch, Valsad and Navsari OBGYN Society. Now, I would like to introduce the conveners of this webinar, that is Dr. Ajay Mane sir and Dr. Jagrati Desai ma'am. Still in Dr. Ajay Mane sir. Dr. Ajay Mane sir is a member of NIMC, PCPNDT wing, Government of India through FOXY, medical legal consultant since 18 years. He's chairperson official AMOGS website, chairperson sexual medicine committee, chairperson adolescent health education committee, past president Aurangabad OBGYN Society, ex-superintendent MGM Medical College Aurangabad, and he has been a health advisor for Sports Authority of India and a charter president for Rotary Club of Aurangabad, Ilai. Sir, I would like to, welcome Sir Dr. Alpesh Gandhi, sir, who is the chief guest of the webinar.
Okay, thank you, Kavita ma'am. At the outset, I welcome Surat Obstetrics and Gynecological Society, then Navsari, Vapi, Valsad, Bharuch, and I convey my gratitude to all the societies who have given their permission to be with us, and particularly to the Jagrati madam who has been instrumental after this webinar. And I'm very much thankful to Alpesh sir. I'm very much thankful to Meenakshi Patel sir, Gopal sir, and Meenakshi Patel ma'am, and the speakers, great speakers, Prakash Bhatt sir, Mohit Sahni sir, then Pandit Palaskar sir, Narendra Gajjar sir, and Chintan Thakkar sir as a moderator, and the chairpersons, Dr. Kurisha Kurishi ma'am, Dr. Hiral Pandya ma'am, Dr. Jagrati Desai madam, Dr. Sheila Maurya ma'am, Dr. Kajal Mangukia ma'am, Dr. Keyur sir, then our great panelist Akash Patel sir, Dr. Arjo sir, Dr. Adit ma'am, Dr. Brijesh sir, Rajal Ben, then Sejal Ben, then Shailaja ma'am, and Pranay Soni, and the greatest people of today's show, Kavita ma'am and Nikunj sir. I welcome you all, and I request Kavita ma'am to proceed with the chief guest and guest of honors. Yes. Welcome.
So, Dr. Alpesh Gandhi sir. Telling Dr. Alpesh Gandhi.
Yes, Alpesh Gandhi sir, who is a president FOXY 2020. He was vice president FOXY 2030. He was governing council member ICOG FOXY 16 to 17. He was a chairperson practical obstetrics committee FOXY 2009 to 2011. I have attended all the webinars and seminars and CMEs done by practical obstetrics committee. It was always a full pack hall. People were sitting on the floor, and up to the foot of the speaker, I have seen those things, and I have got the photographs also. Yesterday, I was searching for that photograph, but unfortunately, I didn't get that. He was past president, Ahmedabad OBGYN Society, 2007 to 8. He was a past secretary, Ahmedabad OBGYN Society, 3 to 4. Then he was a convener, one of the most successful AICOG 2017 at Ahmedabad, attended very nice conference. Past joint secretary, convener, SOGOG, then past treasurer, SOGOG, Society of OBGYN Gujarat State. And he was a national coordinator, emergency obstetric care, EMOC program of Government of India and FOXY. And he is the most successful president of Foxy, who has done the digital marketing of the Foxy and the digital use of the Foxy. In that way, he is the most successful, a very humble person, very academic fellow, and very good friend of all of us. My elder brother, Dr. Alpesh Gandhi sir, I welcome you and I request you for the welcome address and the blessings for all of us.
Thank you, Dr. Ajay, for the kind words and generous introduction. Actually, last sentence of your of my introduction was enough. I am a very good friend of all of you, and your elder brother. I think it was enough. Anyway, thank you very much. Welcome, Dr. Ajay. Welcome to you to Gujarat Societies. Dr. Ajay Mane, Dr. Prakash Bhai, Dr. Gopal Irani, President Sogop, Dr. Meenakshi Patel, Dr. Meenakshi Ben, Dr. Jagruti Ben, Dr. Narendra Gajjar, President Secretaries of Surat Society, Navsari Society, Vapi Society, Valsad Society, and Bharuch Society, all the esteemed faculties. Very good afternoon to all of you. And I am thankful to Surat Society and all of you for giving me this opportunity, inviting me and providing this opportunity to meet all of you. And I think this is a very good platform through which we all can be interconnected with each other very frequently. First of all, I would like to convey happy Holi to all of you. And it is good to see that on a festival of Holi, we all gather here to discuss academics. This shows our dedication towards academic. I would also like to take this opportunity to convey congratulations to all the 2,000, more than 2,500 members of SOGOG, Gujarat State, for bringing down maternal mortality rate in Gujarat. I would say it is now below 70. So we have already achieved SDG goal quite well. We have to achieve it by 2030, but we have already reached to the SDG goal. And as per one meeting with the Secretary Health, Ministry of Health and Family Welfare, Gujarat, actually, according to him, it is now 55 per 1 lakh live birth in Gujarat. So this is quite well. And for that, I would like to congratulate all of you, or all of us. And now Gujarat is among the 6-7 states in India who has brought maternal mortality rate so down. Again, we should congratulate each other for a very massive performance of COVID vaccination in the state of Gujarat. Again, Gujarat is, I can say, we are among the few best states who like a model state for COVID vaccination. And nearly, we can say almost all are vaccinated in Gujarat. So these are few very good achievement of our in Gujarat. It is good to see that we have such a good scientific program today. And Dr. Ajay is there. I have heard him many times. He is always a very good orator, very good speaker. And he is going to speak on, I think, he is going to address medico-legal issues. I think MC Patel has made him a medico-legal person. And I hope he would serve Foxy in because the medico-legal issues are very burning issues, and I think I pray God that he get the opportunity to serve Foxy in a capacity of vice president, so he can address these issues very well. Another topic: neonatal birth injuries, laparoscopic repair of MTP perforation, and panel discussion on root of hysterectomy. All are very, very good topic. Always these are the topics we always eager to hear, and we have esteemed panelist and moderator. I am sure today we will have a very good academic program. So I once again wish happy Holi to all of you, and I wish grand success to this webinar. again, one more thing, I would, on behalf of Rajal Ben and on behalf of member of Sogog, I would like to request all of you also to vote in favor of Dr. Rajal Ben. She is contesting for chairperson of Adolescent Health Committee. We all know that she has done excellent work and very active in adolescent health related issues since last 10 to 15 years. And Foxy has also awarded Dr. Rajal Ben for her this services, noble services. So I wish we all should give her one more opportunity to serve Foxy as chairperson Adolescent Health Committee. With this, once again, best wishes to this webinar, and thank you very much for giving me this opportunity, inviting me. Thank you very much.
Thank you, Alpesh sir, for those kind words and blessings to all of us. And as you said correctly, Meenakshi Patel sir is my mentor and guru in the field of medical legal, and so I am here with my guru. Thank you, sir. Thank you very much. Over to you, Kavita ma'am.
Unmute.
Now moving on to most dear and our lovable president of Surat OBGYN Society, Dr. Jagruti Madam. She has done her MBBS and MD from MS University, Baroda. And she is an inspiring analyst of West India Economic Times World Health Fertility Conclave 2019, Mumbai. She is a primary investigator in various research activities. And she's a life member of various societies and a member of Practical Obstetrics Committee, Foxy 2021 to 2025. She's been practicing for 37 years and one of the very senior most member of our society. We welcome you, ma'am. And ma'am, we would like to for you to introduce our chief guest of honor.
Yes, thank you very much, Dr. Kavita. It's my proud privilege to welcome you all of you to this specially designed mixed bag webinar for all our PVC practitioners today, with a vision to spread awareness and knowledge. Knowledge is the driving force that puts creative passion to work. Be a lifelong student. The more you learn, the more you earn, and more self-confidence you will have in treating your patients. Now, routinely, we deal with two aspects of patients involved serving for women. That is pregnancy, labor, LSCS. Other is gynec diseases and hysterectomy. So we have brilliant stalwarts who will be talking on these topics, and I'm sure it will be very interesting and informative. First of all, I would like to introduce our guests of honor, Dr. MC Patel, sir. Welcome, sir. Dr. MC Patel is practicing obstetrician and gynecologist since last 30 years. He has a special interest in public education and awareness program. He is a medical legal counselor and one of the very few doctors who have done post-graduation in law. And he is one of them. And he takes cases only for doctors. He has represented many associations. He is the past president of Ahmedabad Gynec Society, IMA Ahmedabad. Welcome you, sir. I will like you to say few words of blessing, sir.
Thank you, Dr. Jagruti for kind words. Let me congratulate first Surat, Bharuch, Vapi, Valsad, and Navsari OBGYN Society for designing this very important CME with mixed bag, and Dr. Jagruti in particular for leading this webinar for designing to execution. So, Dr. Alpesh Gandhi, chief guest, Dr. Irani, Dr. Meenakshi two more guest of honor with me, and two learned conveners, Dr. Ajay Mane and Dr. Jagruti Desai, very nicely selected all the topics, neonatal birth injury, and marvelous speaker, Dr. Prakash Bhai and Dr. Mohit Sahni, and chairperson Kuresa Madam and Hiral Pandya. One more important topic, medical legal issues in labor and cesarean section. And again, Jagruti Desai and Sheila Maurya will chair the session. And laparoscopic repair of MTP perforation. It is also one more very important topic which will be covered by Dr. Pandit Palaskar from Aurangabad and will be chaired by Kajal Mangukia and Keyur Padalia. And very interesting panel as far as root of hysterectomy is concerned by Narendra Gajjar. He is master of NDVH, and Chintan Thakkar, master of TLH. So both moderators are doing marvelous work in their own respective field. With all learned panelists, Dr. Akash Patel, Dr. Arjav Dave, Dr. Aditi Narkani, Dr. Brijesh Patel, Dr. Rajal Thakur, Dr. Sejal Nayak, Dr. Sailja, Dr. Pranay Soni, and two learned master of ceremony, Dr. Nikonj and Dr. Kavita Shah. Very rightly mentioned by Dr. Alpesh Gandhi as far as maternal mortality rate is concerned. Of course, in Gujarat, we have already reached the goal, but at the same time, there are few states, still they have maternal mortality rate more than 200. Say for example, Assam, 225. So there are so many states, West Bengal, more than 150. So it is a joint venture on part of government, NGOs, organizations like FOXY, and obstetrician, particularly who are working in rural area. So then only we can achieve that goal of near 70 by 2030, which is given by Government of India. So it is a joint venture only. And for that, to discuss very focused topic in this type of CME and webinars, to update knowledge of our Foxian friends and sharpen the knowledge to deal with any type of emergencies or cases in field of OBGYN. According to me, being a person of medical legal field, all the topics selected today are potential topics or potential area for litigation. You see any topic, neonatal birth injury. Yeah, so it is also potential area as far as litigation part is concerned. And laparoscopic repair of MTP perforation. Again, one more area, labor complication, and you may invite litigation. And as far as root of hysterectomy is concerned, I would like to share one decided case. It was a case for a hysterectomy and consent was taken for abdominal hysterectomy. After anesthesia on table, gynecologist decided to go for vaginal hysterectomy. He started with vaginal route, but there was some profuse bleeding and ultimately abdomen was to be opened. There was injury in ovarian stump, and actually it was pelvic kidney in that particular case. And pelvic vessels were injured, and ultimately kidney of that side, of course it was pelvic kidney, was to be removed. And in this case, inference held by the court was complication may occur at any time. Bleeding is not an issue. Bleeding may occur. It is complication. It is not negligence per se. But change of route without proper counseling and proper consent is not pardoned. So compensation of ₹5 lakhs was awarded to the patient in this particular case. So be aware of all this situation. At the time of counseling, you should be well aware with all the probable complication and probable situation to be handled in future if at all it happens. So if you are well at counseling, whether neonatal birth injuries part is concerned, or in case of MTP perforation part is concerned, or as far as hysterectomy part is concerned, whether you have taken route of vaginal, selected vaginal route, you have taken consent for the same, and for any emergency, you may be compelled to go for laparotomy. So at the time of counseling, this also should be counseled, and if permission is given, then you are out of problem. But not to remember all this, you have to simply visit FOXY website and you have to go for FOXY uniform consent. Under able leadership of our own Dr. Alpesh Gandhi last year, Dr. Nikhil Datar from Mumbai, Dr. Dilip Palke from Pune, and myself, Dr. MC Patel from Ahmedabad, we have prepared almost 30 consent, very useful in our day-to-day practice. Our certain procedures and operation. And in all those consent, we have taken utmost care as far as medical part as well as legal part is concerned. So if you visit, and we are open, you visit, if any suggestion from anybody, we are ready to edit also, because it is suggestive consent, not exhaustive. And it will be useful as far as any kind of medical legal problems are concerned, because it is FOX's uniform consent. And when you take a reference of any organization or any standard guideline, then it becomes a good defense in your favor. So with this, again, congratulating all the societies who have joined this webinar, and Dr. Jagruti Desai in particular. Over to you, chairpersons, for further proceeding.
Thank you, Dr. Meenakshi Patel, sir.
Yes, Alpesh Gandhi wanted to say something.
Dr. Jagruti Ben, with your permission, as Dr. MC Patel has mentioned regarding the consent, FOX's uniform consent, I would like to inform all of you that these consents were prepared in liaison after proper MOU done with Maharashtra National Law University, which is one of the very reputed law university in India. And we have taken expert advice and opinion of 6 different experts from different fields, including one Dr. Kantikar. Last year, you all must be knowing that he had given a judgment against consent, written consent, and it was in very too much in discussion in media and everywhere, and we all were very much afraid because of this type of judgment. And Dr. Kantikar was one of the legal advisor, in preparing these consents. This is just to inform you that we took all care which were required, and how much these consents are authentic. This is just to inform all of you, and these consents are there on FOX's website. I request all of you, please download this consent and take consent on this FOX's uniform consent. So this was our effort to bring safety to all our members and our patients, and it is in 2 parts. So please go through. First, we have also mentioned how to take consent. Please go through it and then take consent of patient. And if you find anything else to be added, you can always inform us. We can modify it. But at present, in Maharashtra National Law University also, they are going to do a lot of research on FOX's uniform consents, and they have also appreciated this project a lot. And some of the students are also going to do dissertation on our consents. So this is a very, very good appreciated uniform consents, and I request all of you to use this consent in your practice. And before leaving, I would also like to thank Dr. Jagruti Ben and Surat Gynec Society. Since last 3 years, in all the installation, I am invited as installation officer and a chief guest. And since I was also there during Dr. Jagruti Ben's installation, and
Yes,
since
sir.
then also I am looking how much actively she is working for Surat Society. Thank you very much, Dr. Jagruti Ben, for inviting me, and I hope I will continue to be there always in Surat program. Thank you.
Thank you.
Thank you,
Alpesh,
sir.
It is rightly said by Dr. Alpesh. There are students from law in state of Maharashtra. They usually have a phone call to us, either me, Dr. Valke, Dr. Nikhil Dada, for discussion of one word or one line for hours together. How it can be challengeable in eye of law, or how it can be useful to any person who has taken a beige of this consent. So, and we are always open to discuss, and we also enjoy to discuss with those students also.
For preparing these 30 consents, we took nearly 1.5 years.
Yes,
Thank
sir.
you so
And
much.
today I have included both consents in my lecture. That is the best part of my lecture. I have included both consents in detail.
Yes, good.
Yes.
Thank you, sir.
Thank you
Thank
so
you very
much,
much.
Dr. MC Patel, sir, and Dr. Alpesh Gandhi, sir, because you have given us a very vital information. And congratulations to both of you for doing this excellent job for all the Foxians. Thank you so much.
Even
You
can I-
rightly follow the word Foxy for all always. And you have been doing this excellent work. Congratulations to you. Yes, Meenakshi Ben?
just one line. Thank you
Yeah,
very
yeah, Dr. Rajan Ben. Yes.
And both Alpesh Bhai and MC Patel sir has talked about maternal mortality. So I'm happy to share that one of the co-panelists, Dr. Brijesh, is my student, and we had worked on his dissertation on maternal mortality. Brijesh is here with us, and the findings are quite good in terms of that we need to work in that area, because we have been concentrating on direct causes like PPH, eclampsia, infection. But what we found is now the direct causes are decreasing and indirect causes, anemia and infections and other causes are increasing. So we need to now work on that area so that we can even decrease from 70 to even lesser figures. So this was our finding and Brijesh's dissertation that we had worked on. So I'm very happy that Brijesh is here with us. Thank you so much.
Yeah. Thank you so much. Now I would like to have CV of Dr. Gopal Irani, sir. Dr. Gopal Irani, presently President of SOGO. He has been selflessly serving people of Kutch since 35 years, and we still cherish the memories of the conference organized at Pranotsav Bhuj under his leadership. A very humble and noble person. Sir, I welcome you to say a few words.
I am very much thankful as inviting me as a guest of honor in this webinar. In selection of this webinar, in mixed bag, so today's topic is very interesting and is very useful in the day-to-day practice. And I also really very much thankful to Dr. Alpesh Gandhi, and everyone should go to the website regarding the consents. And I think everybody should follow this consent. They have taken lots of pain to actually format this all the consents, and it is really useful. At the outset, my regards to Dr. Alpesh Bhai and Foxy, past president, Dr. MC Patel sir, past vice president Foxy, Dr. Meenakshi Ben, my elder sister, just past president Sogo, and our convener Dr. Ajay Mane, Dr. Jagruti Ben. From the Surat OBGYN Society of Gujarat, really always active to arrange different CME and other academic activities, and the whole year is full of scientific often and extravaganza. I personally congratulate President Dr. Jagruti Ben and Secretary Dr. Kajal Mangukia. This time, Navsari, Bharuch, Valsad and Vapi Society, all the President and Secretary are participating in this webinar. Just before 3 days, the impact of mental health on IVF outcome. Just our all South Gujarat Society attended a very useful topic on IVF mental health by Dr. Kanchan Sharma in participating with Kanpur Society. So in mixed bag, if you see this is neonatal birth injuries, really when any injury comes, then it is very troublesome issues, and obstetrician have a very nightmares. And Dr. Prakash Bhatt is will be covered regarding obstetric. He is very intelligent and general speaker. And Dr. Mohit Sahani, who is the president of Neonatal Forum. So we have very experienced and learned speaker today about MTP perforations. So the Dr. Pandit Palaskar, the General Secretary IAG, will be highlighting this and the route of hysterectomy, because today is very debatable, everything, whether vaginal route, laparoscopy, abdominal, whatever route. So really, and Dr. Narendra Gajar and Chintan Thakkar both are very deep knowledge in this subject. I wish this webinar with a grand success, and all my colleagues of Gujarat, the participant of the society, will be more helpful with today's topic about maternal mortality. To reduce maternal mortality in Gujarat, so Gujarat government is also try to implement some Chiranjeevi Yojana. So now some suggestions from our side is the people have taken. and may be implemented in Gujarat to reduce the maternal mortality. Lastly, I wish you happy Holi and Dhulati to all. Thank you all.
Thank you, Dr. Gopal Irani. And now let me have the CV of Dr. Meenakshi Ben. Dr. Meenakshi Patel. Yes, she is the past president of SOGO, immediate past president of SOGO, director and consultant of Sunshine Global and Baroda Hospital. She is also the secretary and treasurer of Menopause Society. She has done tremendous work as regards to hysterectomy, vaginal hysterectomy and laparoscopic hysterectomy. So over to you, Dr. Meenakshi Ben. Please give your blessings.
Am I audible to you?
Yes, sir. Yes, madam. Yes.
Good afternoon. It is a great honor for me to be talking with you today. Very exciting webinar. I am delighted to have the opportunity to address such a talented gathering of our current SOGO president, Dr. Gopal Irani, past president Foxy, Dr. Alpesh Gandhi, past vice president Foxy, Dr. MC Patel, current joint convener of the SOGO, Dr. Ajay Mane, candidate for the vice president of West Zone Foxy, presidents and secretaries of Vapi Society, Navsari Society, Bharuch Society, Surat Society, and Valsad Society. Along with that, all my dear august delegates, as well as all the legend respected faculties. Today's topics are selected is a mixed bag. As advancing technology occurs, there are various recent methods for surgeries also developed, like perforation in MTP. Many a times previously, laparotomy is the answer. But nowadays, don't worry about it. Laparoscope is there for you. This laparoscopically, this can be managed. That Dr. Pandit Palaskar will tell us regarding further details. Previously, hysterectomies were done only abdominally. The vaginal hysterectomies only when there is a prolapse. But nowadays, most of the hysterectomies were done either laparoscopically or those surgeries that cannot be managed vaginally, that can be converted laparoscopically, assisted vaginal surgeries or vaginally. Why this change? Because there are various advantages regarding the laparoscopic surgeries, as shorter hospital stay, fewer internal scars, small external scars heal faster, less pain, less blood loss, and discomfort, as well as quicker run to activities. And advantages regarding the vaginal surgeries are also there, that faster, fewer complications, requires shorter hospital stays, and allows faster recovery compared with the abdominal surgery, hysterectomies. But all these needs how to change ourselves, that is the most important. And today's another topic regarding the medical legal issues in labor as well as cesarean section. Previously, there were 5 to 7 deliveries, 8 to 10 deliveries per a single mother. But nowadays, only 1 or 2 deliveries for each mother. So there are risks and various medical legal issues are also associated with all these things. And risk associated with PPH. Many mothers died in PPH previously, but nowadays there are various technologies and recent advances that saves the mother. Fetal anomalies, congenital malformation with a fetal medicine. Now, these are the today Jagruti Ben has selected the different topics, and congratulations to Dr. Jagruti Ben and her whole team, as well as wishing you all safe, holy, colors of life and colors for the life. And today I personally request to all our SOGO members, Gujarat members, to vote for Dr. Rajal Thakur for the chairperson of the Adolescent Health Committee, and best wishes for Dr. Ajay Mane. He is our West Zone Vice President contestant for the Foxy. Thank you, madam.
So yes, I endorse request of Dr. Meenakshi Ben for both of the contestant, Dr. Rajal Thakur for post of chairperson, Adolescent Health Committee, and of course our own Ajay Mane for vice president, West Zone. So please, what all the president and secretary of respective society should see that both should be well supported as far as voting part is concerned. Thank you.
Thank you, Patel sir. Thank you, Meenakshi, and thank you, Alpesh bhai.
Yes, thank you so much. Thank you, Dr. Alpesh bhai, Dr. Gopal Irani, Dr. MC Patel sir, and Dr. Meenakshi Ben. So over to you, Dr. Kavita, to move forward with our academic sessions.
So beginning with our first session, that is neonatal birth injuries. Neonatal birth injuries, as we know, are those injuries which occur during the childbirth, and they account of fewer than 2% of the neonatal deaths. And for sharing this, and we have Dr. Quresha Qureshi and Dr. Hiral Pandya as the chairpersons for this session. Dr. Quresha Qureshi, ma'am, she's a practicing gynecologist in Padi for last 30 years. She has done her graduation, post-graduation from Surat. She is popular for her clinical skills and has given a number of infertility awareness and adolescent health awareness under banner of Foxy. She has organized TLH workshops, colposcopy workshops under Valsad OBGYN Society. Her areas of interest are high risk pregnancy, infertility, and endoscopy. And we have the other chairperson is Dr. Hiral Pandya, ma'am. She is working at Shivashram Hospital, Bharuch, since 2004 as a full-time gynecologist. She is associated with ESI's branch 2. She worked as organizing secretary of MITSOGO 2018. She is present secretary of Bharuch OBGYN Society. She has conducted many camps and educative webinars for women health and welfare along with various NGOs of Bharuch. She has conducted trials of effect of magnesium sulfate in preterm delivery between 30 to 34 weeks for better neonatal outcome. And her zone of interest is high-risk obstetrics and infertility. So, ma'am, we welcome Quresha ma'am and Hiral Pandya ma'am.
Good evening, everyone. Am I audible?
Yes, yes.
Good evening, everyone, and I am very much thankful to Jagruti ma'am, Team Surat, and Alpesh sir, MC Patel sir, Meenakshi madam, Hirani sir, and everyone. I welcome everyone for such a good conference. It's indeed a knowledge bonanza. Can I get the introduction slide for Prakash sir and Mohit sir? Good afternoon, Prakash sir. Prakash sir was a past president, Surat OBGY Society. And at that time, OBGY Society Surat got the Best Society Award. He was vice president, Federation of Obstetrics and Gynec Society of India 2005, and ex-chairperson for Rural Obstetric Committee, received a Distinguished Committee Service Award. And he was he conceived and executed Foxy program of emergency obstetric care training with John Hopkins University and MacArthur Foundation, 2003. So welcome, Prakash sir. And Dr. Mohit sir. Dr. Mohit Sahani, Director Academics, NICU Institute of Child Hair, Nirmal Hospital, at Ring Road, Editor-in-Chief, Journal of Neonatology, ex-assistant professor, neonatal cardiology and hospital, past president, President NNF Gujarat 2020-21, governing body member NNF Western Zone, fellowship in neonatology, diploma in follow-up of high-risk neonates, neonatal cardiology and neonatal echocardiography at Australia, fellowship in neonatology, neonatal transport and neonatal cardiology and echo, diploma in research project management from University of Toronto, faculty in various national and international conferences, and chief editor of books like Point of Care Neonatology, Ultrasound and Neonatal Cardiology, and another book is Neonatal Echo Made Easy. So we have a good combination of a leading obstetrician and a leading pediatrician for neonatal birth injuries. So welcome, sir, and would like to hear golden words from you.
Dr. Prakash Bhatt, sir?
Yes, please. Am I supposed to start?
Yes, yes, sir.
Okay. Will you please request Dr. Stalin to switch on the presentation?
Yes, sir. Yes, sir. I will do, sir.
Thank you very much. For the purpose of clarity, I and Dr. Sani have divided the injuries to the newborn in two parts. One is hypoxic injuries, which will be taken care of by Dr. Mohit Sani, and traumatic injuries would be taken care of by me. It's apt and appropriate because we, the obstetricians, are generally responsible for inflicting traumas, either on mother or on babies during conducting the delivery. That is number one. And second, the neonatologists have to handle the hypoxic injuries more than the obstetricians. So Dr. Sani would be more appropriate to deal with the hypoxic injuries. We have made one more distinction here. We are going, at least I am going to talk about term newborn, because the preterms are again a different cup of tea. And if we start talking about preterm babies, then it would probably take whole of the webinar, and the rest of the speakers will have to wait for next webinar. So let us confine myself to traumatic injuries of the term newborn. Please change the slide. We all say that truth is always the same and the truth always wins and satyameva jayate. But ladies and gentlemen, the truth doesn't alter, but there is a modification and qualification to it, and that is quickly. Meaning thereby that the truth does alter, but it takes its own time. Do you remember this gentleman, Mr. J. Whitridge Williams? He talked something in 1903, and that is a hint. My friends of obstetrics and gynecology would remember this gentleman. He is the pioneer of Williams' textbook of obstetrics. He wrote single-handedly the first edition of Williams' obstetrics, and now we have several editors and several writers. What did he write in 1903? That in a small number of cases, fractures of the skull are met with. In those days, the accidents usually follow violent attempts at delivery, though occasionally it may occur spontaneously. So even in 1903, he knew that though the obstetrician might create the injuries, few of the injuries might occur spontaneously. And this is for Dr. Ajay Mane and Manubhai Patel, the medical legal persons. You can quote these words of J.A. Whitridge Williams from 1903 if I am drawn to the court for facing a birth injury created by me, that it might have occurred spontaneously. Birth injuries do potentially complicate any delivery. And though most of them are likely associated with operative delivery by forceps of vacuum, some are seen otherwise in uncomplicated vaginal delivery. And my younger friends, even while you are doing a planned cesarean section, please change the slide. We always say the facts speak for themselves, but at times the fact speaks differently also. You view the facts from north and it speaks something else, and you view the facts from south, it again speaks something else. Let us have some facts here, figures and statistics. 3 population studies that included more than 8 million term newborns. It's a huge figure. The overall incidence of birth trauma was 20 to 26 per 1,000 deliveries. The Nova Scotia data says the overall trauma risk was 19.5 per 1,000 deliveries. But there is a good consolidating figure also. Only 1.6 cases had a major trauma, and the rest were all the time minor traumas. The major traumas were most of the times because of failed forceps or vacuum delivery, and the lowest with cesarean delivery without labor. Meaning thereby, if you are undertaking a planned cesarean delivery before the labor begins, you are least likely to traumatize the baby. This doesn't mean, of course, that you undertake planned cesarean section for every parturient mother that comes to you. Please beware. Thus, the most traumatic injuries were minor, and this had an incidence of 18 per 1,000 deliveries. Please change the slide, and I request the audience to remember 18 per 1,000 is the rate. This is a nice table. it says that in spontaneous delivery, 1.2 per thousand had a major trauma. In assisted delivery like vacuum and forceps, the major trauma was in 3.7 and 5.2 per thousand respectively. But if you fail in assisting by vacuum or forceps, the things change, and the things change drastically. The vacuum inflicts trauma in 8.3 per thousand and forceps 7 per thousand. The numbers have got reversed. So those of my friends who have detested the forceps and who have loved the vacuum like anything, please beware. If you fail on vacuum, you are more likely to create traumas as against if you fail on forceps. And here is another eye-opener. If you are doing a cesarean section and cesarean section during labor, you have a chance of 0.4 per thousand of traumatizing the baby. But if you are doing it without labor, it's 50% hard, it is 0.2. But it is there, 0.2 per thousand. So cesarean doesn't guarantee that the baby will not have any trauma or any injuries because of us. Next. This is another record, Maternal Fetal Medicine Unit Network. This is very well known. Those of you who have been undergoing ultrasound training and those of you who have undergone FMF certification for NT would be knowing this outfit, and that Maternal Fetal Medicine Unit Network has studied and said that the trauma associated with cesarean delivery was 400 injuries out of 37,100 operations, a rate of 11 per thousand cesarean deliveries. And if you include everything, remember the first or the second slide, the rate of injury was about 20 per 1,000 deliveries. So cesarean section is not lagging very much behind the vaginal deliveries. And this is for those who have always steadfastly believed that cesarean section is the cure for everything and is the rampant or the panacea as far as the baby is concerned. It's not so. Please keep it in mind. What were the serious injuries in these 400 infants? 88 kyphal hematomas, 11 clavicular fractures, 11 facial nerve palsies, 9 brachial plexopathies, and 6 skull fractures. This is a list, and what a list. Next. So let's talk something about traumatic head injuries. The traumatic head injuries associated with labor or delivery can be external, and naturally, therefore, they are obvious, like you have fractured a skull, or somebody has fractured a mandible, or it can be intracranial, and they may be covert. The fetal head, fortunately, has considerable plasticity and can undergo appreciable molding. We all are conversant with this word molding. Rarely, severe molding can result in tearing of veins, and these veins are intracranial and create a havoc with the newborn. The bleeding may be asymptomatic, but several hemorrhages like subgaleal hemorrhages can be very much life-threatening. In severe head trauma cases, this is something which came to me as a news. Fetal brain tissue can embolize to the heart or lungs also. I never heard about it till I read this. And this is something which really sounds absolutely scary. Next. And of course, we were talking about intracranial hemorrhages because of molding. Let's talk a little more about it. Most aspects of neonatal intracranial hemorrhage are related to gestational age, more hemorrhage in preterm neonates because of hypoxia and ischemia. What is that? Hypoxic ischemic encephalopathy. And my colleague, Dr. Mohit Baisani, would be taking care of it and will be speaking about it in great details. But even in full-term neonate also, there can be an intracranial hemorrhage because of instrumental intervention. And in some newborns, a putative cause just cannot be found. Intracranial hemorrhage may be asymptomatic. The reported incidence might vary with institutes, with workers, and with the authors, but they are found even in spontaneous vaginal and cesarean deliveries also. Once again, let's go back to those 8 million singleton deliveries, where the rate of intracranial hemorrhage was 0.2 per 1,000 births. And how did various agencies who professed to conduct and assist the delivery performed. Vacuum delivery caused 1 in 385 intracranial hemorrhages, forceps 1 in 515, and cesarean delivery 1 in 1210. Mark my words once again, vacuum delivery was more responsible for intracranial hemorrhage as compared to the forceps. Next. This is varieties of intracranial hemorrhages and their severity. There is only one sentence which I would like to say in reinforcing this table, and that is that subdural hemorrhages are extremely serious, and they can cause serious damage to the fetus. And similarly, intraventricular or intracerebellar hemorrhages can create a lot of problems. Fortunately, they are comparatively uncommon. Next. But what happens after the baby bleeds intracranially? What is the prognosis? Fortunately, the subdural and subarachnoid hemorrhages seldom result in neurological abnormalities unless they are very large. Whereas large hematomas are serious, moderate or mild subdural and subarachnoid hemorrhages will come around even without any specific treatment. But if something bleeds in the parenchyma from the intraventricular or intracerebellar region, that hemorrhage causes serious and permanent damage or death. Periventricular hemorrhage rarely causes the type of sequelae that are common in those which are born preterm. So ultimately, rather than these all things which we have been enumerating, what matters and the crux is the term, the preterm or the full term. Next. Spontaneous intracranial hemorrhage has also been documented at some places. And the best tool to detect it is a prospective MR imaging study. And these gentlemen found that 6% of those delivered spontaneously and 28% of those who delivered by forceps had a subdural hemorrhage. They didn't have any clinical findings, and hematomas resolved by 4 weeks in all infants. And that is the only news which can gladden the heart of an obstetrician. Next. This was about intracranial hemorrhages. There is something about extracranial hemorrhages also. I will show you a picture and that will clear everything. Next. We have been mugging up and we have been memorizing these pictures since we were in our MBBS. What is the difference between caput succiderenium and a Keuffel hematoma? That was the pet question of one of my teachers. And then we used to remember that if the swelling ends near the bone edge, it is a Keuffel hematoma. If it overlaps the bone edge, it is a caput succiderenium. But depending upon the layer of the scalp where the neonate has bled, all these things occur. We omit the caput succiderenium because it is not a hemorrhage, but subgaleal hemorrhage and Keuffel hematomas are obvious, differently placed under the scalp, and therefore they have different presentations. Next. Keuffel hematomas are common, and let me tell you, pretty common. In Nova Scotia, this accounted for 80% of traumatic injuries with an incidence of 16 per 1,000. They rarely developed in the absence of birth trauma, and 11% incidence was reported when the babies were delivered by vacuum. And vacuums are notorious for inflicting Keuffel hematomas on the newborn. In the network study, and this I want everybody to note down, that cesarean delivery outcomes also had incidence of Keuffel hematoma 2.4 per 1,000. So if your cesarean baby comes with a Keuffel hematoma, please don't get surprised. Next. And now one more serious situation, and that is fracture of the skull. Though they are rare, they are worrisome because they can lead to serious intracranial hemorrhages. And again, the same French study, 2 million deliveries. The incidence was 3.7 per 100,000 births, and 75% were associated with instrumented vaginal deliveries. These are also occasionally seen with spontaneous or cesarean deliveries. And the lateral fractures are common when the head is tightly wedged and you have to scoop it out, or the assistant has to push it from below vagina to get it into the pelvis back. These are the situations where you might fracture the skull inadvertently. Next. You might injure the spinal cord. If the brain is injured, the spinal cord should not be left out. Overstretching of the spinal cord and associated hemorrhage and edema are, though rare, they are found, and they are there because of excessive longitudinal or lateral traction of the spine or by torsion during delivery, as when you are conducting a vaginal breech delivery or when you are stuck with a shoulder dystocia. Please don't get me wrong. I am not advocating here the vaginal breech delivery, but at times one may be called upon to do it. And at that time, let us be very careful about not traumatizing the spinal cord. Next. This I want to discuss a little in detail, and that is brachial plexus injury. Throughout my career, and believe me, I have been an ardent obstetrician, conducting deliveries left, right, and center. I have got one baby. His age at present is 22 and has been suffering with a permanent brachial plexus injury, residual damages. Injuries to the brachial plexus are relatively common. They are identified 1 to 3 per 1,000 term births. In some series, it is 1.5 per 1,000, and even in cesarean deliveries also. At Parkland Hospital, it is 3.5, and it is generally found in breech delivery and in shoulder dystocias. So if there is a shoulder dystocia, and believe me, shoulder dystocia is something which is a bald from the blue. Even the best of the ultrasonologists and best of the obstetricians have missed shoulder dystocias till it happens. So let us be on guard for that. Next. American College of Obstetricians and Gynecologists really worried about brachial plexus injury, conducted a task force to review the studies. And they said that shoulder dystocia can never be accurately predicted, and axonal death fortunately doesn't occur in most of the cases, and the prognosis is good. Complete recovery is found in 86% with C5 and C6 trauma. That is the commonest. But those with C5 to C7 trauma and damage, only 38% recovers. And if somebody has got a global trauma from C5, 6, 7, 8 to T1, they lead to permanent disability. If there happens to be an associated clavicular fracture, ironically and contradictorily, it is protective for the brachial plexus, because the damage at the clavicle diverts the force and therefore reduces the stretch which we inflict upon the brachial plexus while delivering a difficult shoulder. Next. Can you recognize this? This is a good question for short cases in MD. This baby is having a facial nerve palsy, newborn. Next. Trauma to facial nerve occurs something went wrong.
Sir, now can you see the slides, sir?
Where are the slides?
1 second, sir.
ये क्या आ गया बीच में?
Sir, sorry for the disturbance.
Never mind.
Yes.
Okay, thanks. Facial paralysis may not be detected at birth. After 3-4 days, when you have discharged the baby and mother well, and the mother has gone home and the celebration is over, they realize that the baby's face is not all right. Might come back to you after 2, 3, 4 days. And this can happen even after cesarean section also. Facial nerve damage is more common with low forceps. Spontaneous recovery within a few days is the rule, and we need not be very much perturbed about it, but it is difficult to handle the parents at this stage. Next. Clavicle fracture. I remember we were taught about clidotomies. Some of the obstetricians over here who probably belong to my era might remember that we used to carry out a clidotomy while delivering a dead fetus, especially in anencephalines, because they used to be very, very heavy. In those days, we used to deliver anencephalines at full term, not knowing that it is an anencephaly. These I'm talking about the absence of when the ultrasound was no more there. That would be when you also might have delivered full-term anencephaly.
Yes, yes.
And
sure.
at that time, the shoulder dystocia was very much well known in anencephaly. And at that time, we used to carry out clidotomies. This clavicle fracture, though not voluntarily, but can happen involuntarily, inadvertently in few patients, even with those who doesn't have a shoulder dystocia. And the cause is just simply not known. There is no specific risk factors. At any birth weight, you might have a fractured clavicle. Clavicular fractures do one thing good for us, and that is they protect against brachial plexopathy, just as I told you. Next.
वो वीडियो है ना दिख नहीं रहा है इसमें
You can have some long bone fractures. You can have fracture of humerus while delivering an arm which is extended in breech, or while delivering a reverse arm in the breech. You might have a green stick type of fracture. And at times, now nobody must be carrying out, I am absolutely sure, anybody is still carrying out internal podalic version. That is the procedure which is fraught with this danger of femoral fractures. There is a transverse lie, it is a second coming twin. The first twin is head, you have delivered the head, the baby has come out, and now you find it is a transverse. At that time, you have got to carry out either an internal podalic version or do a cesarean on a second coming twin. And in that situation, this thing can happen. Dr. Stalin, again, something has gone wrong.
One second, sir. 1 second, sir.
Okay, thank you. Next slide. Next slide. We don't hear this word nowadays very much. Dr. Mohit Sani would be better able to enlighten us, throw better light, and that is torticollis. The etiology which has been described is like this, that the sternocleidomastoid injury is very well known in vaginal breech deliveries. There used to be a hematoma in the muscle or in the facial seats, which would resolve very slowly and would produce a cicatricial contraction. When the neck grows, the less elastic damaged muscle does not elongate, and the baby, when matures or when is about 4, 5, 6 years, the sternocleidomastoid is shortened and the head is gradually turned towards the side of the injury, and that is known as torticollis. So varieties of injuries can happen. Varieties of injuries can happen in spite of all our precautions, even with normal spontaneous vaginal delivery and even with cesarean sections. And we can be in serious trouble with these injuries. Some of the injuries might revert on their own. There is very little which we can offer. And when Dr. Sani will talk about hypoxic injuries, probably this picture of injuries is going to take a more serious turn. So I would leave the matters here only and will hand over the next presentation to Dr. Mohit Sani. Thank you very much. Dr. Stalin, I am done.
Yes, sir. I have stopped sharing, sir. Yes.
Prakash sir, it was very nice deliberation, and it was very great information by you, and I'm hearing you after a long time. Thank you, sir. Thank you very much for being here for all of us.
Thank you.
Thank you very much, sir. Thanks a lot for starting this ball running. I would like to thank Dr. Jagruti, Surat Obs and Gynae Society, and all other societies who are a part of this and making me a part of this team. Sir, as told, now I will discuss basically next 10 to 20 minutes regarding mainly the asphyxia, because that is one of the severest thing that can happen to a baby. I hope you can hear me and you can see my slides.
Yes, sir. Very much.
Yes, yes.
So now you can see these people who are playing with fire, and these are the obstetricians. Obstetricians, they really have to play with the fire, and especially in asphyxia, perinatal asphyxia. This is something which make them very hot. And while the time the obstetricians are hot, the pediatricians are pretty cool. At that time, they will be sitting on ice. But after the babies they have come to it, they will have to apply ice on the baby, and that is what is cooling nowadays we do. So that is the story. If somebody is hot, the other one is cool, and when somebody else is hot, the previous person will be cool. So basically, this is just to show you, the basics of perinatal asphyxia, what it is. Your placenta is nothing but an oxygen cylinder, and this is applying the oxygen to the brain. This is the most significant organ that has been hit by asphyxia. If you have any adverse perinatal events, this is what happens to the baby. And who you think this is, this baby or somebody else? What happens nowadays? Who is this? Who is this cock? Basically, he is nothing but obstetrician and pediatricians. They are the person on the सूली पे जिसको चढ़ाया जाता है. They are the ones. So medical legal things come in this. This is very important from that point of view also. So what happens, when any event that prevents the supply of oxygen to our major organs, brain is one of the majorly hit, and this causes hypoxia. And then again, what happens to the fetus or the newborn? The brain is affected. So that's why it's a very long-term outcomes are pretty bad for these babies. So that's why we are worried about it. So this is basically nothing. This is how the pathophysiology events, whenever you have an insult, all the major organs are hit by a hypoxia. It causes ATP depletion, that is a primary energy failure. And then it leads to secondary energy failure, which causes the cell death. And why, whenever we talk about, because nowadays, I will talk about that, a major treatment for this hypoxia, perinatal hypoxia or ischemia, the major treatment is hypothermia, the whole body cooling. And now it has been very well established that it has to be started within 6 hours after the insult, after the birth. If it is later than that, we tend not to cool the babies. So it has to be within 6 hours. Why it is so? Because after 6 hours, the reperfusion occurs, and then along with this primary energy failure, you have the secondary energy failure because of reperfusion injuries, you have irreversible damage. So if you want to prevent this reperfusion injuries, your treatment here, the cooling has to be started within 6 hours after the birth. That is very important. So no, when these babies are born, you know what happens? This is basically the neonatologist or the pediatrician. So the questions have been fired, this is regularly we tend to hear that because I will tell you what maybe why it is, because everybody is tense. So what the bullets will be fired as the regular antenatal care was been taken, and we did, and they are true on their part of obstetricians, that stringent monitoring was been done. I was there for the whole time. Then how it happened? And on top of that, before we could answer this, the attendants, they will come and start sitting on the head. Kisne kiya aur kaise hua? There is one more thing which comes to with this hypoxic insult babies. So before answering to that, why I've shown that slide, that why it is so tense and why we are worried that we could not answer that. We should know the incidence and demographics of everything. What is the incidence and problem of how big is this problem of birth asphyxia? Nowadays, it is being it has come down very nicely. And this is something very good for our neonatal care in India. In developed nations, the incidence is around 3 to 5 per 1,000 live births. And moderate to severe hypoxic injuries are 0.5 to 1 per 1,000 live births, as per the data, which has further been improved. In India, this is around 26 to 58 per 1,000 live births. You see the comparison. And incidence of this moderate to severe from 0.1 to 1 is 20 to 30 per 1,000 live births. So even though from developed nations, yes.
Hello.
Need to mute.
Jagruti ma'am, can you mute please?
Okay. So the thing is, you can see the incidence and the moderate to severe incidence, the difference between the developed nations and India. But I can tell, like I am in India after coming from Canada from last 10, 11 years, I've been settled here. I've seen initially a lot babies used to come with this perinatal asphyxias, but now it has been drastically been reduced. And these figures are 4 to 5 years old figures. The recent ones in many of the papers have come down to 20 to 30. So that is very good thing which is happening, and it is being improving, but still we cannot achieve 0%. Why? See, it occurs at different parts of the intrapartum, peripartum, and postpartum, various stages of the your delivery. This intrapartum thing or antepartum things, most of the gynecologists and obstetricians, they will be observing and handling it. But there is this big chunk of 25% which is unknown. So that's why I told, like, the obstetricians, they are worried. Like, we have been monitoring this baby, we have been doing everything. But even then, how it happened? Because that 25% unknown is unknown. So in their apprehension, they will call to know the cause, what may be the cause of it. And then if you ask me, even we are unaware of that. So that 25% or 25% is idiopathic. Nobody knows about this. It happens. So that's why it becomes a big question in some of the babies, that why it happened, but it happened. Like regularly we see these cases. I'm just going to discuss one scenario. 132 years old, gravida 3, para 3 living 2 mother presents to you with regular antenatal visits. At 39 weeks and 3 days, she presented in labor. She delivered a male infant by normal vaginal delivery. Baby did not cry immediately after birth. And there was nothing antenatally. And gravida 3 mother with big caput. And normally these things happen at odd hours, either when you are sitting in early in the morning in your toilets or you are sleeping in the nights. So you have to eject yourself out and go to these your nursing homes or your hospitals to attend these calls. So then you are amazed, then why this happened to us. This is the thing, that is 20%. We don't know why these things are happening. So that's why our neonatal resuscitation program, even though only 0.3% needs chest compression, 4% needs some ventilation assistant, and only 10% of all the babies who are born need some assistance from a person who is trained in NRP or a pediatrician. But we recommend that all and every birth should be attended by a person who is trained in NRP, neonatal resuscitation program, or a pediatrician. Because these kind of deliveries, when they will happen, and normally they happen in the odd hours, when they will happen, we don't know. So these difficult deliveries, they tend to happen at odd places and odd times. So that's why obstetricians, they always take, antenatal and perinatal good care, and this has shown the results over the years. But again, even the obstetricians are playing their part well. We don't know that delivery may have end up in a bad scenario. So that's why all the deliveries need to be attended by a pediatrician or NRP trained person. And another thing which has come up quite well in the last couple of years, and now it has been included in our neonatal resuscitation program guidelines, delayed cord clamping. I will be talking about that. That is very useful for the babies. And one very important thing in these birth asphyxia or perinatal asphyxia patients is that the pediatrician and obstetrician should adequately and promptly communicate with each other. They both should be on the same table before talking to the parents, because nowadays the parents, they become very notorious. They will be talking something to the obstetrician and something to the pediatrician, and if they are not on the same page, they don't communicate well, they both tend to end up in a trouble. And medical legal is a big problem in this. So you effectively communicate with each other. That is very important for both of the fraternities, obstetricians and even the pediatricians. So now what is this? Now we get smart babies. So these smart babies are when they are born and they become, active and good, smart for 60 seconds, 1 minute. Till then, don't clamp the cord. Now they recommend if the babies are born with the normal vaginal delivery or even cesarean and they have cried, you do all these initial, initiation, stimulation and cleaning on the mother's tummy, and let the cord be there for 60 seconds, for 1 minute, and then clamp the cord. So that is what is delayed cord clamping. If the baby have not cried, only then you shift the baby to the warmers. Otherwise, deliver them, put them on mother's tummy, or put in a tray in the cesarean section, keep it at the level of the mother's tummy, and then delayed the clamping of the cord for 1 minute. That is very important. So the basic management, when we say, is first thing starts with the regular antenatal care, stringent perinatal monitoring. All the deliveries have to be attended by a pediatrician and an NRP trained person. Maintain the temperature. This I will come to that, because if I'm talking about that the temperature, this cooling, whole body cooling needs to be started within 6 hours of life, then why I'm talking about to maintain the temperature after birth? This is very important point, because if cooling has to be started, it has to be started in a proper, adequate environment, not there. So I will be talking about that. So you have to maintain the temperature irrespective of what may be the cause, what may be the issue with the baby. And we always talk about this first golden minute, ABCs for neonatal resuscitation program. So first golden minute, temperature and all those steps has to be followed stringently, and adequate oxygenation has to be maintained. Because if you don't do this, and sometimes these babies who have perinatal asphyxia, within a couple or 2 or 3 hours, they may present like this. So this is a newborn having subtle seizures, having asphyxia and seizures. So that's why we tend to start cooling early. We can prevent, we cannot altogether abolish this, but we can prevent or decrease the incidence of having seizures, and that is the insult for the brain. And now it is very well established, gold standard treatment, evidence-based, and it has been in Cochrane and all the guidelines everywhere. But the caution word is there should not be a temperature variation. So that's why I told that we should not be doing this passive cooling. That now if you see your pediatricians also, if there is a perinatal asphyxia and your pediatrician is saying switch off the warmer so that we can start the passive cooling at that point, that is bad for the baby. At that point, you resuscitate the baby at the normal controlled temperature, no passive cooling by switching off the warmer, because the temperature variations, cooling and then warming, or warming and cooling, causes more harm. So it has to be a controlled cooling. So it has not been advised even by the NRP, and it is harmful. So if somebody in resuscitating the babies in your unit is asking for passive cooling and telling to switch off the warmer so we can start with the passive cooling, discourage that. And this is a lot of studies have been done, and recently our paper has been accepted in PAS meeting. We have the largest cohort of cooled babies of 135 babies in Southeast Asia. And normally in Southeast Asia, the mortality of these bad babies is around 20 to 30%. In our unit, over the last 7-8 years since we have started the whole body cooling, it's around 20%. And we have followed these babies with the growth and development, and we have seen that 70% of these babies, they have favorable outcome. Favorable outcome we consider in those babies in which it is mild till the level they are either they are normal or mild neurodevelopmental outcome is hampered. So mild is, only the behavior changes, sometimes speech or language, but there is no neuromotor deficit. So if it is mild, then it is okay for us. So 70% of these babies, they have favorable outcomes, and 80% of these babies have survived. So this is, we do it with the Critical Mini. It's a device, that has been proper device that has to, and baby ventilated with whole body cooling, and the baby is being covered with the blanket. So if we do that, most of the babies with moderately hit, their outcomes are very good. So what happens, like, in this cycle, what I say, if we do cooling at this step only, all these harmful effects can be controlled by cooling. So that's why the cooling is a gold standard for treating the babies. And the protocol wise, as I told, it has the babies who are eligible for cooling, they have to be started within 6 hours of birth. We conducted one study in our unit, and what we have found in babies in whom we have started cooling after 6 hours of life of the insult, the mortality rate for babies less than 6 hours was around 20-22%. And for babies who were enrolled for cooling after 6 hours, the mortality rate was above 40%. And ideally, it has to be done by servo control. Like I told you, the Critical Mini, which we use, many units, they have Mera cradle. So that is substance, phase change material, or ice packs. So that is not servo control, and that is not ideal. वो एक जुगाड़ है, क्योंकि वो 1.5 लाख का है और ये 15 लाख का है, इसीलिए जुगाड़ is not ideal. And other thing is, the infants who needs to be cooled needs to be more than 35 weeks of gestation. We cannot cool preterm babies. Recently, we got one baby in which the parents 32 weeker, and the parents were counseled beforehand that when the baby will reach, the baby will be cooled. But we did not cool the baby, and it causes a lot of issues. But everybody should know that the baby has to be more than 35 weeks if the baby is eligible for cooling. Other interventions which have been coming up nowadays is erythropoietin is something which can be used and is very cheap also. So this is coming up because xenon is good, but it is very costly in India. And we have tried using, because this xenon, you must be knowing, was being used in Surat in some of the centers in COVID. The patients who were very sick on ventilator were being treated with the xenon. So that from there, but it needs special equipment. Erythropoietin is freely available. We use it in other issues with the preterm babies. So that is very promising and very easily available. Magnesium sulfate, obstetricians have been using, especially in the preterm babies nowadays, which is protective for the cerebral palsy. So that can be used, but there are very side effects. So this is one thing along with the cooling, which can have a very promising results. So in the end, what we have seen is regular antenatal care, good perinatal monitoring, all the deliveries attended by a pediatrician and NRP trained person, maintaining normal temperature, proper ABC is maintained in the first golden minute, achieve the target oxygenation, no passive cooling, maintaining hydration and whole body cooling are the key things to get the favorable outcomes even in few of the very badly hit perinatal asphyxia babies. So these are my take home points. And again, in the end, I would say, if you want to play with the fire, only play if you have ice handy with that. And that is, what is the ice handy with you is the controlled hypothermia and proper devices. Otherwise, don't play with it. Thank you very much.
Thank you, sir. Great talk again by Mohit sir, because these are the facts which we don't usually read or can hear by from our gynecologist fellow. So thank you for the knowledge, sir. Thank you very much.
So now moving, yeah.
Thank you.
Puresha ma'am. Hiral ma'am.
Yes. Thank you, Prakash sir, for making and for highlighting that seizure is not a rescue to.
Okay, I was muted. Okay.
Thank you, Bhumi, for taking out this burning hot topic and handling and enlightening us and teaching us to handle in a cool way. And one the message is that obstetrician and pediatrician should be on the same table before discussing with the parents to avoid from them. Thank you, sir.
Thank you, Prakash sir and Sane sir, for your informative lectures on both topics. Were very much informative, and it is very much required in this era. Thank you very much.
Now moving on to the our second session, that is medical legal issues in labor and cesarean section. We have our own Dr. Jagruti Desai ma'am as a chairperson and Dr. Sheila Moria ma'am. As we all know, she is the president. Dr. Jagruti Desai ma'am is the president of our society, and she is a senior gynecologist practicing for 36 years. And
Dr. Kavita, move on. I'm already.
Yes, ma'am. Yes, ma'am. Yes, ma'am. And Dr. Sheila Moria, ma'am, is passed from Golden Medical College. She has worked in Birla GP Hospital. She's a teaching faculty at CPS Board DGO, and at present, she's the president at VOGS for the year 2021. Her special interest is in high-risk pregnancy. Jagruti, ma'am.
Yeah, over to Sheila, ma'am. She'll introduce Dr. Ajay Mane, sir.
Sheila, ma'am.
Thank you, Dr. Kavita. Good afternoon to all. Thanks, Dr. Jagruti Desai, ma'am, and Surat Obstetric Gynec Society for inviting us as a part of this webinar. Now, I want to like to introduce Dr. Ajay Mane, sir, for today's webinar. As everybody know, Dr. Ajay Mane, sir, is a member of NIMC, and he's a medical legal consultant since 18 years for free of cost, chairperson of official AMOJC, chairperson of sexual medicine, chairperson of adolescent health, and past president of Aurangabad Society, and a trainer and health advisor also. So welcome you, sir, for today's webinar. And also I wish you for your election, sir. Sir, over to you,
thank
sir.
you.
Dr. Ajay Mane, sir.
Thank you, Maure, madam. I was saying just to skip that, but I was muted rather. Thank you, Jagruti ma'am. I will move on to the slides very fast. Yes, 2 routine questions. Is it seen and am I heard?
Yes, sir.
Hello. Yeah.
Yes,
thank you. Thank you. Yes. Medical issue in LHS and labor. And my gratitude to Alpesh Gandhi sir, my mentor Dr. MC Patel sir, senior sir from Bhuj, Dr. Gopal Irani sir, and Meenakshi Patel madam, ex-vice president, ex-president Shogao. Thank you. Then Dr. Jagruti Desai madam for her every efforts to conduct this. Then Prakash Bhatt sir, Mohit Sahani sir, Qureshi ma'am, Sheila Mora ma'am, Kajal Mungukia ma'am, Keyur Padalia, and Pandit Palaskar, my friend. Then Narendra Gajjar sir and Chintan Thakkar sir, senior most fellows, agreed to come today. Akash Patel, Dr. Arjadas, Aditi Nadkarni, Dr. Rajal Thakur ma'am, Dr. Sejal Naik, Dr. Shalja Bhaskar, Dr. Nikunj Navadia, and Kavita Shah for the MOC and conducting the best webinar. And Surat, Navsari, Vapi, Valsad, Bharuch, Obedient Societies, President Secretaries, and the delegates. Thank you very much for giving me chance to be with you all on the auspicious day of Holi. I wish you all happy Holi and happy Dhuli Vandan to you. And may God gives you all the colors of life and end the black color of COVID in incoming days. Okay. Over to the discussion. The situations. Patient came with the pregnancy full term for first time for labor. Miss unregistered patient, and her age is 17 years. What next? This is the situation very routinely seen in rural areas, rather not in rural areas. Hello.
Yes, sir. You're audible, sir.
Yeah. Okay. Fine. Thank you. Then see what is the situation. She is coming for first time. Second, coming at the age of 17 years for full-term pregnancy in delivery. So we cannot refer her if she is in second stage or the first late stage. so we cannot refer. If she is in first stage and very early stage, then we can refer the patient, or we can deny the patient also. Unless and until there is a life-threatening condition, you can deny, that is your right. Okay, first thing. Second thing, her age is 17 years. She is married, she is unmarried, doesn't make any difference. She is less than 18 years completed, then POCSO Act applies here. What is the POCSO? Protection of child from sexual offences. Many of the consultants, they utter this as a POSCO, but it is a POCSO, and it is formed in 2012, then amended in 2019, and there is one amendment that if you don't inform the police or the child welfare committee in beforehands, whenever you come to know that there is a pregnancy with less than 18 years, then we are liable for a punishment or the imprisonment of 6 months. 6 महीने की जेल हो सकती है हम लोगों को अगर हमने इन्फॉर्म नहीं किया तो. So inform on a paper and have a receipt of that information. That is not FIR. Mind it, it is different. It is only information to police. This is for your information. That's all. You have to write it down. This is not FIR. Police आपको insist कर सकती है कि आप ना इसको FIR कर दो. बहुत सारी जगह ये हुआ है. But don't get frightened by the police. उनको बोलना नहीं, हम FIR नहीं करेंगे. हमारा काम है सिर्फ inform करना. You just give me the receipt. That's all. Your work is over. Then follow protocol. We have followed documentation. Everything you must make a document that on the admission, what was the finding 1, 2, 3, 4, 5, 6. That's why you cannot deny the patient, you did not shift the patient or whatnot, and treat her. That is our basic duty, to treat her. Okay. एक बार पुलिस को इन्फॉर्म किया, बाद में आगे क्या आप कर, अगर वो एमटीपी के लिए भी अगर आई है तो पुलिस का जवाब होने के बाद उसको एमटीपी कर सकते हो. Next question. Do we need a consent for a labor? Can a patient give consent who is in active stage of labor and pains? Can a relative give consent for the patient? Okay. And what is the answer? Do we need a consent for a labor? Yes, 100% yes. Can a patient give consent who is in active stage of labor and pains? No, because consent is given in sound condition of mind and body. Here, the pains are there. She is in agony. The sound condition is not sound by body and mind also. So at that pain condition, she cannot give consent. So what is the remedy then? What Patel sir has prepared, give the information on the last ANC visit, take the consent. You can take the consent beforehand, very early, maybe 10 days, 15 days early for the normal labor, that is acceptable. And if it is not taken, then at the time of labor, you need to take the consent of the relative who is standing outside the labor room, who is a near relative. Section 88 says that you can take the consent of a near relative. Okay, can a relative give consent for the patient? Yes, that is the answer. And see, this is the part which Patel sir and Alpesh Bhai was discussing. They have given a very beautiful book called as Uniform Consent, and this is Uniform Consent. And on page 95 to 104 of that book, consent for a natural childbirth, vacuum and forceps. Please read the information below carefully. This is the information. There are two parts. One is information part, second is undertaking part. Information part includes everything, every aspect of this normal delivery. What can happen, what can be the possibilities, what will go wrong, and what you are going to do with the patients, maybe procedures, what can be the output, morbidity, mortality, everything is explained. See part 1, information about the procedure, name of the procedure, augmentation of the labor, episiotomy, instrumental delivery, forceps ventus. Now Bhatt sir told us about the all consequences of forceps ventus, normal delivery, cesarean section, everything we know. Repair of perineal tear, it may not be possible to predict beforehand. Obviously, we cannot predict, but we can just have a suspicion कि ये हो सकता है, ये हो सकता है, ये हो सकता है. That is called as anticipation. हम जब गाड़ी चलाते हैं तो हम क्या anticipate करते हैं? ये सामने वाला अचानक रुकेगा, इधर वाला इधर घुस जाएगा, या इधर से कोई बच्चा पैदल या तो कोई कुत्ता बीच में आ जाएगा. ये जो हम anticipation करते हैं ना at the time of driving, that anticipation you must have with your patients. ये पेशेंट इधर लैंड हो सकता है, ये पेशेंट पिपिश में जा सकता है, ये पेशेंट का रप्चर हो सकता है, ये पेशेंट का टीयर भी हो सकता है, और बेबी का आपने सर ने अभी बोला वैसा एस्पेक्सिया भी हो सकता है. अभी तो आपको रिकॉर्ड 21 ईयर्स रखना है. एस्पेक्सिया हुआ, उसका ब्रेन का डैमेज हुआ, तो ही में ग्रो टू 18 ईयर्स एंड एट दैट मोमेंट ही कैन सू यू इन द कोर्ट ऑफ लॉ, एंड उसके लिए उसका रिकॉर्ड हम लोगों ने रखना है. हमारे पैर पे कुल्हाड़ी मारने के लिए हमने कुल्हाड़ी उनको रख लेना है कि 18 साल के ले भाई कुल्हाड़ी मार हमारे पैर पे. लाइकवाइज, बट यू हैव टू फॉलो द That's why everything is to be explained. अगर आपने उसको explain किया है, आपने पूरा उसका taken care किया है, so you are not negligent. As Patel sir said, कि complications can be there, bleeding हो सकती है, but you have not diagnosed the bleeding is a negligence. You have not treated the bleeding is a negligence. Bleeding is not a negligence. Okay, ध्यान में है? Okay, consent of labor, उसका मीनिंग क्या है? Following medical interventions में needing added augmentation मतलब क्या? Episiotomy मतलब क्या? इसलिए I have taken only headings. Everything in detail is given in that book, in that 10 pages. Episiotomy, instant delivery, during the delivery, emergency cesarean section, and emergency cesarean section का everything. क्या क्या हम कब करते हैं, क्यों करते हैं, उसका आउटपुट क्या होगा, उसका पर्पस क्या है, डिस्क्रिप्शन, बेनिफिट, अल्टरनेटिव प्रोसीजर्स एंड कंसिक्वेंसेस ऑफ रिफ्यूजल ऑफ द प्रोसीजर. ये सबसे मेन बात है. पेशेंट हमेशा हमको बोलता है कि नहीं, हम सीजर नहीं करो, नॉर्मल डिलीवरी कराओ, और बाद में बोलता है हमने तो बोला था करो, आपने नहीं किया. सो वी आर एट दैट मोमेंट, इधर जाओ कि उधर जाओ. दैट इज कॉल्ड एज धर्म संकट. एंड धर्म संकट इज ऑलवेज देयर. एज मोहित सर सेड, हमारे वो गला काटने की छुरी के नीचे हमारी मुंडे हमेशा रहती है. ओके, and this is the procedure basically, what they have given, consequences of refusal of procedure. Next, infection specifically related to the instrumental delivery of microorganism, excessive bleeding during delivery, morbidity in natural and normal delivery, cerebral palsy अभी सर ने बताया, cerebral palsy, other birth injuries, सर ने तो everything has given in detail. Anesthesia के बारे में बताएंगे, because you need to have a separate consent for anesthesia if she is going for the cesarean section. Cesarean की अलग consent है, anesthesia की separate consent है. And in rare conditions क्या क्या आ सकते हैं, rare conditions वो भी यहाँ पे they have given it very well. And sign patient का, ये हमको information मिला, that is the sign. Instruction to the patient. What is the instruction? Please bring this paper when you come to the hospital for getting the surgery procedure done. Means everything is informed to the patient. अगर ये उसको नहीं मालूम है, ये नहीं आती इंग्लिश लैंग्वेज, उसके नीचे एक सेंटेंस लिखना है कि the information which is given in this pamphlet has been explained to me in my own language. ओके, ऐसा लिखना है कि मुझे ये सब समझाया गया है मेरी मातृभाषा में, और उसका नीचे साइन लेना है. साइन के बाद में उसका अंगूठे का एक छाप लेना है. लेफ्ट थंब इंप्रेशन ऑफ राइट हैंडेड पर्सन एंड राइट थंब इंप्रेशन ऑफ अ लेफ्ट हैंडेड पर्सन, बिकॉज दे मे डिनाई दैट द साइन इज नॉट माइन. Doctor has done forgery, but they cannot deny that the thumb impression do not belong to them. We can prove that the thumb impression belong to them only. And this is second part, which is the undertaking. Patient's name, age, years, residing at, full address. This is not a blanket consent. Blanket कैसे क्या? मैं डॉक्टर अजय माने को कुछ भी करने की परमिशन दे रहा हूँ, वो कुछ भी कर सकते हैं, कुछ भी एनेस्थीसिया कर सकते हैं, कुछ भी ऑपरेशन कर सकते हैं. That is blanket consent. वो that is not accepted by law. But this is a basically just a minute. हाँ संग्राम, तुला थांबावं लागेल 10 मिनिट सरांसोबत थांब, माझं लेक्चर चालू. So this is undertaking, okay, where we need to get. And what is the last sign? Sign of patient, sign of doctor, and 2 witnesses. Why? Because unless and until doctor and patient do not sign, this is a contract. Both are signing, then and then only it becomes a valid consent. अगर दोनों में से एक ने भी नहीं किया तो it becomes a invalid consent. और दोनों की तरफ से एक एक विटनेस होना चाहिए. विटनेस का उसके इंफॉर्मेशन से कुछ लेना देना नहीं. विटनेस का लेना देना किस चीज से है कि ये साइन मेरे सामने किया गया. That's all. That is for the witness purposes. Okay. चेक क्यूरडा जाकर लगा तो क्या करेंगे, लेबर एनालिसिस लगा तो क्या करेंगे. That is also given in that. What is next situation? IUFD G4P3L0 type 2 diabetes mellitus, very bad patient, present at 39 weeks with IUFD on admission. एडमिशन पे उसका IUFD का सोनोग्राफी लेके आई कि बच्चा गया है, मैडम मुझे एडमिट करो. यू आर गेटिंग द पेशेंट एडमिटेड, एंड उसमें आपने पूरा लिखना है. उसमें आपके एडमिशन नोट्स आर वेरी इंपॉर्टेंट, बिकॉज that will only prove that the patient was having IUFD while coming to your hospital, and that death was not occurred in your hospital. Okay, so you are free of allegation of negligence. You are treating the patient after IUFD. Okay, और उसमें अगर आपका ये registered patient है तो उसमें क्या क्या आपको सहायकारी हो सकता है. It did not come for the checkup and advice. हमने तो उसको बुलाया था, follow-up के लिए नहीं आई, उसको लिख दो. Didn't come for the follow-up. आप एक handwriting आपने लिख देना है. That's all, because you are expert. Whatever you are writing on the paper is considered as correct. Document it. Did not get blood sugar done regularly and early. Document it. Did not take insulin as advised. Document it. And did not maintain fetal movement count as advised. Document. That becomes a contributory negligence. What is a contributory negligence? It is a negligence on the part of patient, not on the part of doctor, and that is helpful to the doctor, because we can prove that this is not our negligence. This is a patient part negligence, that is contributing. Okay, then again second case IUFD. क्या है, प्राइमरी विथ सिवियर PIH, प्रेजेंट्स एट 39 वीक्स विथ IUFD. सेम, अब इसमें भी वही चीजें हैं, did not come for checkup, did not get blood pressure checked, did not take proper treatment advice, and did not take maintain fetal movement count as advice. ये आपके फॉलो अप में हर बार आना चाहिए. सो विद बंच ऑफ इंडोर पेपर वी कैन प्रोड्यूस की कोर्ट के सामने. देखिए हमने इसको बोला था, इसने ध्यान नहीं दिया, वी आर but we have performed our duty. Next situation, patient is in PPH and you have not done the blood grouping prior as patient was your registered patient in ANC. Is it negligence? Obviously yes, because blood grouping is your mandatory investigation for the registered patient. If she is an unregistered patient coming for the first time, then you are not negligent. But if she is a registered patient and you have not done the blood grouping and she is in the PPH and she is negative, you have not prepared the blood, or you have not kept ready the blood, or the reservation is not done, then you are at a negligent state. Civil versus criminal negligence. Civil negligence में आपको compensation देना पड़ेगा, criminal negligence में आपको जेल भी हो सकती है. Compensation तो देना ही पड़ेगा. Both can be there in criminal negligence. If it is a severe, then it becomes a criminal. If it is a simple, then it becomes a civil, and compensation देना पड़ता है. Do we need a consent for CS? Obviously yes. Can a patient give consent who is in active stage of labor? No. Again relative comes here, and relative. Uniform consent का मैंने जो दूसरा पार्ट बताइए, this is the second part. Page number 104 of book. It gives a complete information about the cesarean section. 94 से यहाँ तक normal labor है, ये cesarean. Consent for cesarean section. Please read the information below carefully. Same thing, they have given every detail. Name of the procedure, cesarean section, the most common type of cesarean section, लोअर सेगमेंट सिजरियन सेक्शन, उसका मीनिंग क्या है कंप्लीटली बताया गया है उसमें, पर्पस क्या है, इंडिकेशंस क्या है, डिस्क्रिप्शन ऑफ द प्रोसीजर, एवरीथिंग इज इन्फॉर्म. देन बेनिफिट्स ऑफ द प्रोसीजर, और सॉरी अल्टरनेटिव ऑफ द प्रोसीजर, कंसीक्वेंसेस ऑफ रिफ्यूजल ऑफ द प्रोसीजर, ये भी बताया गया है उसमें. तो ये जब तक पेशेंट को बताएंगे तब तक वो बोलेगा हमको तो पता ही नहीं था, ऐसा नहीं किया तो ये नहीं होने वाला है, या तो ये हो जाएगा. Likewise, they say they are hostile all the time in the court of law. Okay, so don't trust the patient. Trust your document and trust your protocols. That's all. Then you are safe. Outline of substantial risk: anesthesia, excessive bleeding, infection, injury to surrounding structures. Every individual is different because we are giving the same treatment to the two patients, and one patient is responding, second is not responding. That the body response, it is a responsible for the outcome. No, that is the every individual is a different. That is the meaning of that point. Morbidity, neonatal morbidity, very rare conditions also they have explained. All details notes of anesthesiologist must be taken with the handwriting of anesthesiologist. Notes must be different and the consent must be different. Need separate consent. Then emergency section, part of the normal, basically everything is explained here. I am not going into the detail. You can go and read. It is a very nice document they have given us. Thank you, Patel sir, and thank you Alpesh bhai for that purpose. They have saved at least 2 years of our life. Purpose, description, benefit, alternative, same thing. And undertaking, sign of patient, doctor, witness, 2 additional points. Okay. Then question: how many years do we need to maintain record? Labor 21 years, any procedure 7 years, it's 5 to 7 years by advised by Foxy. Then MTP 5 years, PCP 2 years, CPA 2 years, but after maybe 4 years the patient is lodging a complaint and the discretion is with the judge. He can accept or she can accept. Okay, ये बहुत potential case है, इसको accept करना जरूरी है. I'll accept. After 4 years also they can accept in amendment. They have done this. That is very wrong thing for the doctor side, but they have done it. So CPA at least 2 years तो है ही है, और insurance 7 years ये ambiguity है 7 years वो बोलते हैं, पर insurance हर साल का रखना चाहिए. Okay. Situation: unregistered patient came in early labor, not ready for any investigations and ask for admission and delivery. Can we deny? Yes. Early labor hai, so we can deny. Send with proper documentation. What is documentation? Uska on admission, what was the condition, and on sending, what is the condition? Consent of referral must be taken by the patient, by the doctor of the patient, and then uska refer करना है. उसका referral sheet उसके साथ में दीजिए. आपका एक आदमी उसके साथ में जाना चाहिए who is a expert in that, maybe nursing staff or a brother, not a ward boy or assistant doctor can, अगर वो बहुत ज्यादा बेकार कंडीशन में है तो. ओके. एंड कीप अ फोटोकॉपी ऑफ रेफरल शीट. बाद में पेशेंट बोलेगा मेरे पास नहीं है, तुम तुम्हारा देखो. So we need to produce that. Registered patient with routine follow-up came at full term in labor and insisting for normal delivery. Routine है ये and not ready for CS needed. अब इसमें क्या करेंगे? ये क्वेश्चन मैंने पटेल सर से पूछा था. पटेल सर क्या आंसर ये है? तो रिकॉर्ड प्रॉपर फाइंडिंग, व्हाट आर द फाइंडिंग्स, उसका डिसेंट कितना है, स्टेशन का है, डायलिटेशन कितना है, हेड कहाँ स्टक हुआ है, कितनी देर से स्टैटिक पोजीशन में है, उसके लिए आपको पार्टोग्राम लगेगा, है ना. तो पार्टोग्राम इज वन लुक, इट प्रोड्यूस ऑल द इंफॉर्मेशन इन वन लुक. सो पार्टोग्राम में आपको ये करना है. उसके बाद में फीटल रिकॉर्ड है, सीटीजी है, उसके स्ट्रिप्स भी जोड़ने पड़ेंगे आपको. इट इज लीगल डॉक्यूमेंट एवरीथिंग. एंड नेगेटिव कंसेंट, व्हाट इज नेगेटिव कंसेंट? पेशेंट इज नॉट रेडी फॉर cesarean section is a negative consent. And refer with all protocol if patient want to go. Accompany the patient till that next hospital. Same situation है and patient not ready for shifting, then उसका everything पिछले केस की जैसा एंड डिनायल ऑफ शिफ्टिंग एंड नेगेटिव कंसेंट, उसका भी अलग से कंसेंट लीजिए एंड देन गो फॉर द नेक्स्ट प्रोसीजर. आप राह देख के कर सकते हैं. हैंड प्रोलैप्स का केस आया, आपको पीडियाट्रिशियन लगेगा, यू नीड टू टेक इट टू द ऑपरेशन थिएटर. काउंसिल अबाउट द कॉन्सिक्वेंसेस डॉक्यूमेंटेड. सर ने जो बोला ना ब्रैकियल प्लेक्स इंजरी 89% रिकवरी हो जाती है, उसमें से 30% लोगों की कभी कभी नहीं होती है, लेट होती है. ओके, तो ये जो है एवरीथिंग मस्ट बी एक्सप्लेन टू देम. Signature of witness, consent for procedure, pediatrician must be present during procedure. Fortunately, nowadays we are having pediatrician for all deliveries. That is good for us because we are having one extra expert person with us who is knowledgeable about the pediatrics, and that will save in the court of law if something goes wrong. Take proper consultation of other fraternity too. अभी neurologist आ सकते हैं, orthopedic surgeon भी आ सकते हैं. Same thing with the cord prolapse. कॉर्ड कोलैप्स है तो कितनी देर से है, घर में कितनी देर थी, ट्रांजिशन में कितनी देर थी, कितनी देर वो पेल्विस और हेड के बीच में वो कॉर्ड फंसा हुआ था, पल्सेशन कितनी देर तक गायब था. वी नेवर नो द आउटपुट ऑफ द बेबी. उसका एस्पेक्सिया कितना हुआ है नहीं हुआ, ये भी नहीं मालूम. सो काउंसिल अबाउट ऑल द कॉन्सिक्वेंसेस डॉक्यूमेंटेड. वो पेशेंट इतनी कंडीशन में नहीं है तो उसका जो रिलेटिव बाहर है उसको काउंसिलिंग करो, उसका साइन ले लो एंड एक्सप्लेन करो. अगर ये भी टाइम नहीं है तो यू कैन हैव अ वीडियो कंसेंट. वीडियो कंसेंट कैन डू नाउअडेज. They are accepted by the court of law. वीडियो कंसेंट लेके भी आप कर सकते हो, मोबाइल भी कर सकते हो, सीसीटीवी कैमरा विद ऑडियो रिकॉर्डिंग उसमें भी कर सकते हो. बट वो पटेल सर हमेशा बोलते हैं कि दैट इज अ डबल एजेड स्वॉर्ड, क्योंकि आपने अगर कुछ चीजें मिस कर दी उसमें एक्सप्लेन करने की, दैट माइट बी कॉट बाय द अपोजिशन लॉयर, सो यू आर इन ट्रबल. सो बी कॉशियस. जो भी है डॉक्यूमेंट पे लीजिए, उसको डॉक्यूमेंट देखिए, पॉइंट उनको एक्सप्लेन कीजिए, दैट्स ऑल. एंड विच डॉक्यूमेंट? दैट यूनिफॉर्म कंसेंट. दे हैव गिवन अस वेरी नाइस डॉक्यूमेंट. कीप ऑल रिकॉर्ड्स, रेफर बेबी इमीडिएटली टू एनआईसीयू. ओके, देन प्रीवियस एलएससीएस, इसमें गिव ऑप्शन मोड ऑफ डिलीवरी. सीएस है, टोलैक करना है, उसका जो भी है दोनों का इफ एंड बट बताना है उनको. ओके, टोलैक में रप्चर के भी चांसेस बताने हैं उनको, बाकी भी बताने, डेहिशंस और रप्चर दोनों. Counsel all positive and negative points of the mode of delivery, particularly scar adhesions or rupture. Then keep proper notes of short intervals. Why short intervals? Routinely हम भी पार्टोग्राम में बोला 4 घंटे में पीवी करो, कुछ लोग बोलते 3 घंटे में करो, पर अगर इसमें डेहिशंस की चांसेस है तो उसमें आप आधे घंटे में करो. वह एक जूनियर को वहां बैठा के रखो, हमेशा उसके पेट पे हाथ रखने का. या तो एक बार बोली क्या रे मेरे तो पेन गायब हो गए, मतलब क्या हुआ, अंदर फटा हुआ है कुछ तो भी. सो that is to be observed very seriously, and that's why it is a short interval. Second opinion is needed and it is beneficial if you have taken a second opinion of maybe junior or maybe senior, but a person who is expert in obstetrics, then it will be beneficial. Jacob मैं तो केस में डिटेल में नहीं बोलना चाहूंगा, पर it is very helpful to us so long as a doctor follow a practice acceptable to the medical profession of that day. He cannot be held liable for negligence. ये इन्होंने दिया सुप्रीम कोर्ट ने, तो बहुत अच्छा हुआ है कि हम हर चीज में निग्लिजेंट हम प्रूव नहीं हुए. ये केस के अपने ऊपर अच्छे उनके इफेक्ट है. ओके, सो व्हाट कैन बी रेमेडीज? कंफर्म चेकलिस्ट were correct, explain the relatives in a scientific way, then out of court settlement can be the option. अब इसमें क्या हो सकता है कि हम पैसे देंगे, बाद में वो 2 महीने बाद फिर से आके पैसे मांगेंगे. That is not the way out. What is the way out? लोक अदालत is the way out. हर डिस्ट्रिक्ट प्लेस में लोक अदालत is there. A retired judge is there, district judge. We can go to the district judge, explain our side. The patient will come, explain patient side, and the judge will decide the compensation if it is to be given. If it is not to be given, वो बोलेगा नहीं दे सकते, ह्यूमैनिटी तौर पे हम उनको देना चाहते हैं, आपने बोला तो थ्रू कोर्ट यू कैन पे, एंड आफ्टर दैट वो आपको दुनिया में कोई भी कोर्ट में आपके ऊपर केस नहीं कर सकता है, बिकॉज उसमें डिग्री निकलती है, वो डिस्ट्रिक्ट लेवल के कोर्ट की एक ऑर्डर रहती है कोर्ट की. देन यू आर सेफ. ये पैसे लेके जाएंगे, 2 महीने बाद दूसरा लीडर आएगा उसके साथ में बोलेगा फिर और 2 पैसे, तो क्या करेंगे? नहीं कर सकते. ओके, कोर्ट केस लॉयर, ये बहुत डेंजरस सिचुएशन होती जा रही, बहुत पैसे बढ़ते जा रहे हैं. सो इसलिए आपको मेडिकल इंडेमनिटी होना बहुत जरूरी है. ओके, एटलीस्ट 1 करोड़ की रखिए, 2-3 इंसिडेंट्स के लिए रखिए. उसमें और एक ग्लिच है, कि आप स्टाफ भी उसमें कवर कीजिए, ठीक है। मेनी टाइम्स इट हैपेंस दैट ओनली डॉक्टर इज कवर्ड, द स्टाफ इज नॉट कवर्ड। और उसमें उसमें और एक ग्लिच है आगे का कि सुप्रीम कोर्ट में 2-4 केसेस पेंडिंग है, उसमें कहा गया है कि अनलेस एंड अंटिल द मेडिकल इंडेमनिटी कंपनी इज नॉट मेड पार्टी, दे आर नॉट पेइंग द इंडेमनिटी चार्ज, पैसे जो भी है आपको, है ना। तो उनको भी पार्टी बनाने की कोशिश करो, आपके वकील को बोलो उनको पार्टी बनाने की। चार्ज क्या रहते हैं 304A, डेथ बाय नेग्लिजेंस। 304 इज कल्पेबल होमिसाइड, उसमें ज्यादा है सजा 2 to 7 years, इसमें मैक्सिमम 2 years इम्प्रिजनमेंट इफ प्रूव्ड, है ना। उसके बाद डिफेंस ऑफ डॉक्टर क्या होना चाहिए, कॉन्ट्रीब्यूटिंग नेग्लिजेंस, आई टोल्ड यू, ड्यूटी डिस्चार्ज अकॉर्डिंग टू प्रिवेलिंग स्टैंडर्ड्स, ICOG, RCOG, WHO, ACOG, ये स्टैंडर्ड हमने फॉलो किए, वो हिसाब से वो प्रोड्यूस करो, इधर से डॉक्यूमेंट अपना जो ट्रीटमेंट किया वो प्रोड्यूस करो, देन यू आर फ्री। एरर ऑफ जजमेंट यहाँ लागू नहीं होता है। Precaution against negligence, written informed consent, develop good rapport with the patient and relatives. If something goes wrong, they will revert back, no problem. Keep full, accurate, legible medical record documentation. This is the main point where we can have our defense. Never guarantee a cure of 100%, and complication took place, then keep the reference ready for the court case. Okay, you need to. This is a certificate given by a quack. We are not doing this, so anticipate the problem. I told you, be ready for that system. Keep proper documentation, keep blood ready, always keep a parallel system ready, and documentation about what protocols, partogram, nothing was missed, done everything according to prevailing standards, and all consents and proper documentation, legitimate records. Take home messages, follow all protocols, document it, train staff rakhiye, because at the time of emergency they will start running here and there, ये नहीं मिल रहा है, वो नहीं मिल रहा है, वो नहीं मिल रहा है। So train staff रखना चाहिए, उसमें उनका रेगुलर ड्रिल बहुत जरूरी है। क्रिएट सिचुएशन, अभी सिस्टर लोगों को जमा करने को बोलना, अभी अपने पास PPH का पेशेंट आया है, वो पल्सलेस है, अब क्या करेंगे बोलो, 1 2 3 4 5 उनसे ये रिपीट करवा लो, दैट इज अ ड्रिल। रेगुलर अगर ये करते हो आप, सो दे विल बिकम एक्सपर्ट, एंड एट द टाइम ऑफ रियल इंसिडेंट्स दे विल हेल्प यू, बिकॉज यू आर इन एग्यूनो। तो उसमें और 2-3 नंबर आप दीवार पे रखिए, आइडियल चार्ट्स रखिए, उनको हर हफ्ते में उनको रिपीट करने लगाइए चार्ट्स, देन दे विल बी गेटिंग अकस्टम। Keep good relation with the colleagues, because everybody will be enjoying your bad situation. Only colleagues are there to help you. So help your colleague whenever needed, and the colleague will help you. Okay, I am not going deeper. So kindly save my number. You don't need my number, because my guru is there, MC Patel sir. He is there. He will help you. And if he is not available, I am always there to help you on the phone. This is Oman Paron in Israel. This is in India. This is in India. This is in India. And this is my humble request to all of you to kindly vote. There are 2 posts for West Zone. Kindly vote for me for 1 post. Second is your choice. And kindly remember this photo and the name, Dr. Mani Ajay. On ballot paper it will come like Dr. Mani Ajay, not Ajay Mani. So thank you very much, and kindly vote for me. And thank you Jagruti Ben, and thank you all societies for giving me the chance share my views with you. And thank you Patel sir for giving me the knowledge, and your mentorship is best for me for my whole life. Thank you sir.
Thank you, Dr. Ajay Mane sir. This was an excellent discourse, giving all the details about documentation, counseling, consent, and what all should be done when the patient comes with labor and LSS. As we all know, the patient, walk-in patient who comes for delivery, many a times they always expect that the result will be very nice. They will have a normal delivery, and the baby will be fine and everything. The obstetrician also counsels with them regarding the same. But then suddenly a catastrophe occurs, and when the situation becomes critical, we have to save our skin. And Dr. Ajay Mane has helped us very well how to save our skin and how to do a litigation-free practice. So thank you, Dr. Ajay Mane sir. Excellent. And we'll definitely download all the consents from the Foxy website. And
yeah, it is very nice book, madam.
Yes.
It is very nice.
Thank you so much.
Thank you very much, madam. Thank you.
So Dr. Kavita?
Yes. Moving on to the third session, that is laparoscopic repair of MTV perforation. And we have Dr. Kajal Mangukia and Dr. Keyur Padalia as the chairpersons for this session. Dr. Kajal Mangukia is the consultant gynecologist and medical director of Orchid Hospital. She is the practicing for the last 15 years in Surat. She has participated in various national, international conferences and workshops, and she has active social work in breast cancer, cervical cancer, adverse and gynec problems. She runs Foxy recognized advanced infertility training, ultrasonography, IU, and basic laparoscopy from Mumbai. Dr. Padalia. He is the proprietor of Shankar Hospital, Valsad. He is Diploma Laparoscopy from Germany. He is the treasurer of Valsad OBGYN Society 2020 and secretary of Valsad OBGYN Society 2021. I think so, Dr.
Dr. Kavita, you may move forward if the chairpersons are not there. I would like to introduce Dr. Pandit Palaskar. Hello.
Yeah. Yes, ma'am.
Yeah, Dr. Pandit Palaskar is here. He's the chairman and chairman Endo World Hospital, Aurangabad, Maharashtra. He is also the organizing chairperson of Endo World 2018, chairperson of Endoscopy Committee, AMOX Maharashtra, vice president of Aurangabad OBGYN Society, and he has been invited as operative faculties. And I have listened and seen him operating also. So we welcome you, sir, for your discourse today. Welcome, sir. Over to you.
Yeah, good afternoon, everybody. Let me thank at the outset the organizers of this webinar, the President Secretary of Surat Obstetrics and Gynecological Society, along with Navsari, Vapi, Valsad, and Bharuch OBGYN Society, and Dr. Ajay Mane for giving me this opportunity to share our views regarding the management of the MTP perforation. Friends, the medical termination of the pregnancy is the very common surgery we do as obstetrician and gynecologists in day-to-day practice. And I think every gynecologist, every obstetrician has faced this complication during our either PG tenure or maybe in the practice, because as we move on to do the complex cases, nowadays we have the more and more cases of previous cesarean sections, and patients are coming for the, they are opting for the small family size. So we are getting more and more cases for medical termination of pregnancy, and maybe sometimes we land into this complication. Nowadays, I think we have moved to this MEA, and previously we used to use this steel suction cannulas. The incidence was more. And also nowadays, everybody has the facility of ultrasound, and I think in difficult cases, we can take the help of the ultrasound guided dilatation and suction evacuation. And so we can minimize this MTP perforation. MTP perforation, nowadays, most of the medical termination of the pregnancies, they are carried by the medical methods. We have misoprostol, this mifepristone combination, and rarely we go for the second trimester abortions. So day by day, with the advantage of medical methods of termination, we are having less and less medical this perforation by the suction cannula. So when you land into this problem, recognition of the problem is very important. The surgeon can feel himself or herself that suction cannula, there was giveaway sensation, and even the patient is under anesthesia, patient can feel there was a slight pain into abdomen. So this is how you can diagnose. Suppose you are in doubt, you can take the help of ultrasound also. And every perforation, the management, not necessarily surgical, you can do the conservative management, and what caused perforation, what was the cause of the perforation, that is also very important. When the perforation is caused by the small dilator, you can observe the patient, you can watch her pulse, BP, the abdominal girth, and you can do the ultrasound. By ultrasound, you can come to know whether the medical, the MTP is complete, whether any residual products are remaining, whether there are intestinal coils or momentum is coming into the uterine cavity. or you can judge the amount of the hemoperitoneum the patient has after the perforation. Also, you have to explain to the patient and the relatives the risk of injury to the intraperitoneal structure. Suppose the perforation is caused by the suction cannula and that to the metallic cannula, you have to suspect there is chance of injury to the omental vessels, the bowel, maybe small intestine or large intestine. If the patient is deteriorating, suppose the pulse is rising, there is fall in the blood pressure, the abdominal girth is rising, there is guarding and rigidity, and there is increasing hemoperitoneum. This patient you need to manage by surgical method, maybe by laparoscopy, or if you have the facilities of laparoscopy, you can do laparoscopy. If not, you can do laparotomy. And in some patients, there are chances of injury to the bowel and the surrounding structures like bladder and ureter. In those cases, you have to take the help of the GI surgeons and urologists, depending on the extent of the injury. So these are the indications for the surgical management: signs of perforation, which may be tachycardia, fall in blood pressure, abdominal distension, intraperitoneal bleeding. Ultrasound is suggesting of hemoperitoneum, that to increasing hemoperitoneum. Obvious signs of perforations. In some patients, the loop of the intestine or omentum may come through the cervix and vagina, and in those cases, it is sure there is a large rent into the uterus, and there is possibility of injury to the bowel loops and the omental vessels. Signs of sepsis, if the diagnosis is not done in early period, or suppose the MTB is done by the quacks or illegal methods, this patient, they may present with the signs of sepsis. And when the diagnosis is not certain, you are not sure whether there is perforation or not, it is better you put laparoscope and confirm the diagnosis. So now we'll see a few videos. This is a patient of 8 weeks MTP, and the doctor doing it, she felt the suction has gone little upwards, and there was give sensation. You can see the omentum was coming through this rent into the uterine cavity, and the ultrasound showed there is hemoperitoneum. So we posted this patient. That patient we shifted to our hospital, and we put the scope, and you can see there is a hemoperitoneum, and there was a perforation on the posterior wall of the uterus just below the fundus, which is the most common site. When the uterus is retroverted and surgeon pushes the dilator in the upward direction, there can be the perforation on the entry wall. So once you diagnose the perforation, you have to suture it. This is a suturing of the perforation on the posterior wall of the uterus. Take deep through and through wide, and that suture will again approximate the myometrial fibers, as well as it will achieve the hemostasis. So suturing is better. If the perforation is very small, you can just cauterize it, but I always believe you should approximate the muscle fibers, and this will again minimize the chance of perforation during the subsequent pregnancy. As this omentum was coming through the rent, we are observing the omentum, whether there are any injury to the omental vessels, and also always trace the bowel. The both small bowel and large bowel has to be traced both on both surface on either side, because if you are observing one side, the perforation there might be chances of injury on the other side of the bowel. So you have to examine the both sides of the bowel, use a traumatic grasper, and trace the small bowel from the ileocecal junction till the second part of the duodenum. Also, you have to see the sigmoid and the rectum, and then give thorough lavage. Now, this is another patient, little advanced pregnancy, 12 weeks. And she was a case of the previous 2 cesarean section. You can see the site of the cesarean scar. So this gynecologist also she felt the dilator has gone on the left lateral side of the uterus, and she was suspecting there is a perforation on the left lateral side. On ultrasound, it was showing there was a collection of the products of conception in the left broad ligament. So we took this patient for the laparoscopic procedure. Just like myomectomy, the vasopressin is injected into the myometrium, and you can watch the blanching, and this will reduce the vascularity and the blood loss during surgery. And now you can see the bladder is dissected from the anterior surface of the cervix and vagina by the lateral window technique, just we do during the laparoscopic hysterectomy. And once the bladder is mobilized, you will see there is a hematoma which is extending into the broad ligament. Also, whenever there is a lateral perforation, you have to suspect the injury to the ureters, because ureters, they are passing on the both sides laterally. And this is a dissection of the, you can see the bladder is densely adherent to the site of the previous cesarean side. This is the dissection on the left lateral side. The bladder is mobilized completely. See, you can see this is the hematoma on the posterior aspect. So to be very sure, you have to dissect the course of the ureter from the pelvis brim till the insertion into the bladder. And you can see the peritoneum along the left uterosacral ligament is open, and you can see the ureter there. So whenever you suspect the injury to the intra-abdominal structure, you have to trace them. This is the lateral pelvic wall dissection on the left side, because there was extension of the hematoma and the products of conception on the left side. So the lateral pelvic wall peritoneum is dissected, and you can see this is the course of the ureter. As this perforation was at least 1 week back, you can see there is a lot of fibrosis and necrotic debris are there in the broad ligament. This all necrotic material, the products of conception, they are evacuated with the help of the suction. And the ureter was lying at the base of this perforation. So this is you can see the course of the uterine artery, and the ureter is lying below it. As this is old perforation, it was attracting a lot of adhesions. If you need more separation of the bladder, you can push the bladder at any time. So the proper exposure of the surrounding organs is very important. Take out all these devitalized necrotic tissue with the help of the harmonic, or you can use bipolar and scissor, and take all these necrotic material. You can see this is the course of the ureter. The ureter is going below the uterine artery. And then we are very sure there is no injury to the surrounding structures. The ureter is lateralized completely. And this is the site of perforation on the left angle of the scar of the cesarean section. There was small, the suction was going through it. So you have to suture this scar. Before suturing, you have to refreshen this all fibrotic tissue, the necrotic material. It has to be excised out completely, and then it will be sutured with the barb suture. To have the better healing, the refreshment of the wound margins is very important. You have to take all this fibrotic tissue, the debris, the necrotic material, it has to be taken out. And as the cervix is already open, it was taken out through the vagina. Otherwise, you can put this material into the endobag, and you can take out through by enlarging one of the secondary ports. But in this patient, as there is a rent into the cervix and vagina, you can take the advantage of that, and it is taken out, and then it will be sutured. So you can now see the healthy tissue margins with good vascularity. As this patient was into the reproductive age groups and she was willing for the future childbearing, we need to have good scar of the uterus, and good proper approximation is very important. So like myomectomy scar, you have to take deep bites and have the good surface to surface approximation. You can put either a uterine manipulator or you can put a dilator into the cervix and going into the uterus. So this is a barb suture we are using to close the wound. This is the first layer, and to reinforce the first layer, the second layer is also taken. You can see there is good surface to surface approximation, and the uterine muscle fibers, they are approximated, and it will give the good scar with good scar integrity.
Ma'am, actually.
Here you can see the course of the ureter completely passing, which is away from the site of the wound. So we are very sure. You can see the good peristalsis with good vascularity of the ureter on the left side. On right side, the ureteric dissection is not required because the wound is on the left side. And this patient, she can conceive after 3 months. So this is the complete pelvic anatomy. And obviously, she will need a cesarean section during the next pregnancy. This is an advanced pregnancy of 20 weeks. And in this patient, the medical termination was carried by the general practitioner, and there was also perforation on the anterior aspect. She was advanced pregnancy 20 weeks, and we are expecting a lot of vascularity and bleeding. So in this patient, we will be ligating the uterine arteries. So whenever you suspect intraoperatively, there will be bleeding. So you have to do the uterine artery ligation at origin on the both sides. This is lateral pelvic wall dissection. You have to open the retroperitoneum lateral to the infundibulum pelvic ligament and identify the course of the uterine artery, the internal iliac artery, its branches, and the most lateral branch that is coming medially is the uterine artery. So this is a uterine artery which is turning medially, which is the medial branch of the internal iliac. And I also identify the course of the ureter. So this is the ligation of the uterine artery at origin. On the right side, this can be reversible. You can see the uterine artery at origin. On the left side, as this perforation was also diagnosed after 10 days, and there is a lot of fibrosis is there. So lateral dissection was little difficult. So we are doing this uterine artery ligation on the left side by the medial approach. Again, here give a cut on the peritoneum along the border of the uterosacral ligament and identify the course of the ureter and the uterine artery. So this is ligation of the uterine artery on the left side. If the patient is interested in future childbearing, you can place the reversible knot, that is uterine artery ligation by the shoelace technique, and at the end of the surgery, you can remove the knot. Now, once the uterine arteries, they are taken care, the bladder is dissected from the entry wall of the cervix. In this patient, fortunately, there was no communication into the peritoneal cavity. So we are very sure there is no chance of injury to the intraperitoneal structures like bowel, whether it is small intestine or large intestine. And it was good for patient also because even after 10 days, you can see there is no signs of peritonitis. You can see there is a lot of debris is there. The tissues are edematous. There is a lot of necrosis, and there was a lot of blood clots are there. So all these they are taken care with the suction. All these debris, the necrotic material, they are sucked out, and the site of perforation is identified. In this patient, there are two perforation, one at the cervico-uterine junction and other what was at the anterior wall of the vagina. This is a womb forceps which is passed through the cervix and it will be passed into the uterus so that the continuity of the cervico-uterine canal will be maintained. And then refreshen the womb margins, take out all these debris, necrotic tissue so that you have a healthy tissue for the placement of the suturing. And then the suture, once the wound edges are refreshened, you have the healthy tissue with good vascularity. That suture by intracorporeal suturing. Again, in this patient, we have used the barb suture. The advantage of barb suture is it gives uniform tension on the suture line, and it definitely it has the ease of suturing. So just like a myomectomy scar, you have to approximate the wound edges. Again, in this patient, we trace the course of the ureter on the left side. As the wound was, there was extension on the left side and it was normal. Now you can see the placement of the Foley's catheter, and the bulb was inflated with around 5 ml of the normal saline. And this is, you can see the second perforation on the anterior wall of the vagina. So you have to suspect the chances of multiple perforation and also the chances of injury to the surrounding organs like bladder, ureter. And if there is communication to the peritoneal cavity, you have to suspect the injury to the intestine. So in this patient, the thorough preoperative preparation is very important. On ultrasound, there was collection into the left broad ligament entered to the in between the uterus and bladder, and there was no collection into the peritoneal cavity. So we suspected there is no chance of injury, but intraoperatively you have to confirm the findings. This is the perforation on the anterior wall of the vagina. This uterine perforation is sutured in 2 layers with good surface to surface approximation like a myomectomy scar. It is sutured in 2 layers. It will give good approximation as well as it will achieve the hemostasis. Then this is a closure of the vaginal wound, vaginal perforation with the vicryl suture. This is perforation. This was perforation on the anterior wall of the vagina. In this patient, you have to, when there is a perforation on the anterior wall of the vagina, you have to rule out the injury to the bladder also. Then once the all perforation they are sutured, you have to achieve the hemostasis, give thorough lavage, take out all these necrotic material. And definitely in this patient, after thorough lavage, you have to keep the intra-abdominal drain because as this was a old perforation, there are chances of collection. So drain is always helpful in such cases because whatever small amount of collection is there, it will take out and it will act as a window what is happening into the intraperitoneal cavity. This patient was kept on the higher antibiotic for 5 days and she is fine. So this is the advantage of laparoscopy. You can take care of the all perforation on whatever site of uterus it is there, whether it is anterior wall, posterior wall, or whether it is extending into the broad ligament. Whenever there is extension to the broad ligament, you have to identify the course of the ureters. And this is the final picture. So to conclude, laparoscopy plays a very vital role in the management of the MTP perforation. It helps in diagnosis and management of the perforation. And in complicated cases, if you suspect injury to the surrounding structures like ureter and the bladder, if you are not used to handle these ureter and bladder, you can always take the help of urologists, colleagues, or GI surgeons. And definitely laparoscopy, even if you land in complication and you manage this complication with the help of minimal invasive surgery, definitely the gravity of the complication is minimized. The relatives will be happy. Otherwise, if you open this patient, there is a big laparotomy scar and there are chances of emotional breakdown. So friends, thank you so much for your patient hearing and giving me opportunity to share our views. Once again, there will be obstacles, there will be doubters, and there will be mistakes, but with hard work, there are no limits. So thank you so much. I again appeal everybody to vote and support our dear leader, Dr. Ajay Mane, who has devoted his so many lives for the growth of our organizations. He is always there to help the FOXI members. Maybe it is related to PCPNDT Act, MTP Act. He is always there for our help. So we need such people in FOXI. Thank you so much.
Thank you, Dr. Pandit Palaskar. Excellent demonstration of different cases, first trimester and the second trimester, with beautiful videos. The repair of the perforation and the ligation of the uterine address. So excellent. It is like MTP is the only procedure which is a blind procedure.
Yeah.
And only if you perform an MTP, then you'll come across an perforation. So I think we'll have to call you when one encounters a perforation. Excellent, sir. Thank you so much.
Thank you so much.
Yeah. We move on. Yes, sir. Dr.
Yeah,
MC Patel wants to say something.
Just to congratulate Dr. Pandit.
Thank you, sir.
Excellent talk with carry home tips and a good video.
Thank you, sir.
Yes, welcome.
Thank you. It is nice to see you after so many days. Thank you, sir.
Welcome.
Over to you, Dr. Kavita.
Yes. Now moving on to the last and the very interesting session of the webinar, that is panel discussion on routes of hysterectomy. Our moderators are Dr. Narendra Gajjar sir and Dr. Chintan Thakkar. Dr. Narendra Gajjar sir needs no introduction. He is well-known personality. His past president SOGOG 95-96, an organizing chairperson of SOGOG and West Zone Year Conference FOXI. Dr. Chintan Thakkar. Dr. Chintan Thakkar, he is present President Bharuch OBGYN Society and past President IMA Bharuch. He is present many lectures and papers in various conferences, and his key of interest are laparoscopy and infertility. Now introducing the panelists of the panel, Dr. Akash Patel. He is trained in fetal medicine at Ahmedabad, and he has passed his MBBS from MP Shah Medical College, Jamnagar. Next, please. Dr. Arjav Dave. He has done a fellowship in industrial health, Maharaja University. He has worked in research assistant at Vanderbilt University. Next, please. Dr. Aditi Nadkarni. She is embryology. She runs embryology. She has done embryology training from Cleveland, USA, and Sydney. Everyone knows her. She's one of the directors of the Nadkarni hospitals. Next, please. Dr. Brijesh Patel. He has passed from BJ Medical College, Ahmedabad, and he has done more than 3,000 complex laparoscopic surgeries at Valsad. At present, practicing at Valsad, Padi Hospital. Next, please. Dr. Rajal Thakkar. Ma'am is Professor OBGYN NHL Municipal Medical College, Ahmedabad. She's at present President AOGS. Dr. Sejal Nayak, she's Director Consultant at IVF Special Delhi and Lao Hospital, Women's Hospital, Surat. At present, she's EC member of IAG. Next, please. Dr. Shailja Maskar, she has passed her DGU and MD from Surat, and she is working at Valsad, practicing as obstetrician Valsad for last 25 years at Maskar General Hospital. Dr. Pranay Soni, he has done his MBBS from, he has done his DGO from Pareva Institute of Medical Sciences, Loni, and he's working as laparoscopic and gynecologist for last 14 years. Sir, hello, we can hear you, sir.
Am I audible? Thank you. Thank you very much. Thank you, Dr. Jagruti, for organizing a very nice webinar. Today, you are doing a very good activity, being a president of Surat Gynec Society. Thanks, Dr. Kajal, Dr. Ajay Mane, and Dr. Palaskar, and all persons who have helped in organizing this webinar. I am very happy to learn that I have got a plethora of expert panelists with me. And really, I would like to say that I am very fortunate to have some people who are really well experienced in laparoscopy, some of them are very well, very senior, and some of them are really good academicians. So I've got a mixed bag. The real word, what we say is a mixed bag of panelists. I am happy with this. And so I'm really happy to have Dr. Chintan Thakkar with me as a co-moderator. So we'll start with the session directly.
At the outset, very good evening to everyone. Am I audible?
Yes.
Yes.
Okay. May I know who are present, who are our panelists are there?
Yes, sir. Akash is here.
All
Yeah,
are
fine.
there. All are there. All are there.
Oh, very good.
Good evening, sir.
Please wait.
Rajal from Ahmedabad.
Yeah, madam. Good evening.
Keem cho?
That's fine. Keem cho tame?
That's fine.
Gajar sir, namaste.
Namaste, namaste.
Ajay Mane, Aurangabad.
Yeah, Dr. Mane. Just now I'm trying to display the presentation. Please wait.
Yes, sir. Yes, sir. Yes, please carry on. Thank you.
Yeah. Right. Mail.
Okay, till sir is setting his screen, I take this opportunity to welcome all our esteemed panelists. I think Dr. Akash is there, Dr. Rajal ma'am is there. May I know anybody else from our panelists is there?
Hello, sir.
Yes, Sejal ma'am, welcome. Today we are having a fantastic session so far. We have learned the complications of the delivery, neonatal aspect and obstetrician aspect. We had a fantastic talk on the medical legal things, and finally the beautiful presentation of laparoscopic management of MTB perforation. So this is the last session. Just like to inform the panelists that, okay, whatever we are discussing regarding the best route of hysterectomy, here we consider a gynecologist with an average skill I mean, Dr. Sejerman, it's not. We are not discussing the laparoscopic stuff of your skill or Rajal ma'am of your skill, but then okay, this would be a generalized discussion. So as we can decide and we can pick up some message for our routine gynecologist, for our fresh colleagues who really are going for the career. I would hand over to Dr. Gajjar sir with his presentation, and I'll be assisting him.
I'm trying to share the screen, but somehow or the other, there's some difficulty in that. But still, we will start with the.
Sir, you can send your PPT to the host who is organizing. Digital partner, so that they can, or you can send it to Chintan Bhai so that he can project from. It's
so now it is visible.
It's
so
visible.
You just need to.
Sir, it is seen now.
Sir, visible.
Yeah, please click from start, sir.
Yeah, no problem. Click on next.
Yeah. I'm trying to move the slide.
So now it is not seen.
Yeah.
So I'm so sorry, I was absent for 20 minutes. I had gone to OT with the permission of Jagruti ma'am. So let me share some comment on Pandit Palaskar's lecture. I have seen this lecture so many times. The perforation taking place is not a negligence, but not diagnosing that perforation and not treating the perforation is a negligence. Okay, negligence is a complication. Complication takes place. It is given in your book. Complication may take place by anybody's hand, and if somebody says that I have not done any complication, so okay, so they have started.
Yeah. So we all know that it is second most common surgery on women during reproductive age group. And if we go back to the history, we don't know when first vaginal hysterectomy was performed. We know that first abdominal hysterectomy was performed in 1843, and first total abdominal hysterectomy was performed by Richardson in 1929. And Harry Reach, as we all know, that he did first laparoscopic hysterectomy in 1988. And then onwards, we have not stopped. Robotic hysterectomy has come into the existence, and advances and innovations are going on. So that is making the picture more and more confusing, that what type of hysterectomy should be done and by which route. So just like Dr. MC Patel, I remember him, he is asking in his first slide, is it worth discussing? Akash, we will start from there.
Yeah, sir, it is worth discussing because this webinar is only for this.
The topic that has been selected is okay, fine. So these are the common indications. I am not repeating, but I would like to ask Dr. Pranay that out of this chart which I have displayed, how many conditions are for the benign regions where hysterectomy is being performed? Please calculate and tell me.
So for adenomyosis?
Please calculate. DUB, fibroid, adenomyosis. Please calculate from the chart which I have said. I have displayed.
Okay.
See, this is the percentage of hysterectomy for a particular indications. And if you look at it, 80 to 90% of the hysterectomies are performed for benign conditions of the uterus. Agreed?
Yes, sir.
Do all panelists agree with me?
Yes.
Agreed.
Okay, fine. So, may I ask Dr. Arjav, what are the different types of hysterectomies?
Yes, sir. The most commonly known hysterectomies, we can say abdominal hysterectomy, vaginal hysterectomy, non-distant vaginal hysterectomy, total laparoscopic hysterectomy, and the most advanced one, the robotic laparoscopic hysterectomy. we can, another term we can use is laparoscopic assisted vaginal hysterectomy also.
So route and type are different.
Yes.
Say for example, vaginal is a vaginal route.
Yes.
But TLH not necessarily vaginal route.
Yes, sir.
Because you might, you might remove it by morcellation and all these things. So in that case, it is not typically vaginal.
Yes, sir.
Yeah. So I request Dr. Chintan to go on.
Okay. The next question is, who will decide the type of hysterectomy? May I ask Dr. Sejalman this question?
Yeah, good evening. Good evening, esteemed auditors and panelists. So who will decide the type of hysterectomy? It's of patient and the treating surgeon, because it should be compatible with the patient also and cumbersome with the skill of the operating surgeon also. So I would rather the mode should be decided with both of them.
Yeah, that was a perfect answer, Sejalman.
We can give them. So it should be the best priority. What best for her.
Correct.
The doctor will decide the type of hysterectomy, will counsel about, will give different options to the patient, and ultimate final authority is patient, I think.
Yeah.
Anything from other panelists?
Usually in practice, it occurs. The doctor will counsel only the route what he or she is comfortable with.
Yes, I agree with
It depends on the skill of the surgeon, and it depends on how proficient he is, whether he can do NDVH like Gajjar sir and Dipesh bhai can remove a very big size uterus, and somebody who is not very comfortable with that NDVH route, they can go for the abdominal hysterectomy as well. So depending upon the skill, so newly passed and those who have not having much confidence in NDVH, then they go for the abdominal route as well. So it depends on the experience of the surgeon also.
Absolutely.
So, theoretically, sir, patient will decide the route of hysterectomy, but practically, the choice of surgeon will, according to his choice, surgeon will counsel patient for route of hysterectomy.
Also, I would like to comment the indication of the hysterectomy. If you are doing it for ovarian mass or like a big fibroid, you would prefer rather than vaginal, you would prefer to go via laparoscopic or abdominal route. So yeah, indication also is important while you are deciding the type of hysterectomy.
We are coming to the to that question, that how would you determine the best route for the hysterectomy for a particular patient afterwards. But as a concluding, I would just like to say that when you are counseling the patient for a hysterectomy, then you should discuss all the types of hysterectomy, all the routes of hysterectomy with the patient. You may ask the patient that you are comfortable with particular route, rather whether it's an abdominal or a vaginal or a laparoscopic route. You may discuss your experience, that how many, regarding how many surgeries and complications, and that with the patient, so that patient can take a better decision. And then this sort of cafeteria approach should be offered to the patient, and then let the patient decide regarding what route she is comfortable with. So thank you, panelists, for that excellent answer. Now, the next question would be to Dr. Aditi. At what time it is decided, and is it essential to counsel the patient about the type of the hysterectomy prior to surgery? And should we include it in our consent? Dr. Aditi is there? Okay. May I just shift the question to Dr. Rajal, ma'am?
Okay. It has to be decided beforehand that which route you are going, and we have to counsel the patient and the relatives regarding the same. Also, we need to counsel regarding we are preserving the ovaries or not. Of course, depending upon any lesion in the ovary, we are removing that or not. But If the patient is young, then we have to tell about the preservation of the ovary, and then if the patient has crossed the age of more than 50, 60 years, then we can counsel for the removal of the ovaries also. So we have to counsel beforehand, and we have to take the consent beforehand. It is very, very essential. Otherwise, we end up in a medical legal problem, and we have to go to MC Patel sir and Ajay Mane sir for their advice. So it is always better to take, counsel the patient beforehand about the route and the complications that can happen. Also, that we have to counsel well in advance.
That was an excellent point, Rajal ma'am, that you should, when you are undertaking a hysterectomy of any patient, you must discuss whether you are going to remove the ovary or not, and if yes, why yes, and if no, why no. You have to explain all the pros and cons. We have seen many young surgeons, just removing the ovary on their own and without taking consent, without explaining anything. So that was a very good point and a carry home message for all, that if you are undertaking hysterectomy, do explain the patient regarding whether or not to go for an oophorectomy and why. Thank you, Rajaman.
There is a famous case of Samira Kohli versus Dr. Prabha Manchanda.
Yes.
And in that case, they changed the course of surgery during, on operation table. Obviously, patient is in no condition to give consent, and her relatives give consent. Now, her relatives giving consent on behalf of patient, is it valid? That is one. And second thing, can you change it suddenly during operation? So what should we include in consent prior to all these situations arise? Dr. Ajay Mane, I think he's busy with the phone.
So we need to counsel about the possibility. Sometimes you are having a big uterus and trying to remove by NDVH, and at one point of time you are unable to do so, then you have to go for the abdominal route. So we have to counsel beforehand that if not, then we have to do it abdominally. So we have to take that consent, and also the patient's consent prior hand. So larger bigger counseling session can go ahead, but then we have to counsel about all this possibility. We have
Yeah. Can I have my comment?
Yeah.
Most welcome, sir.
Yes. In a proxy uniform consent, just we mentioned during innovation part, we have in undertaking part, we have mentioned that also. If at all there is unforeseen, unpredictable situations happen, then I give my full authority to take decision in good faith of mind to my doctor. One thing. Or patient can give option that way also. If it is unseen, unpredictable situation happens, some of my relative name is waiting outside operation theater. Doctor may discuss with him. I have given my full authority to take decision on my behalf to my relative, Mr. or Mrs. So-and-so. So that both line we have included in our consent during undertaking of the patient. So whenever you face this type of situation, if you have counseled patient well in advance, and if patient has given you a consent to change route of hysterectomy, then you are free to change.
Yeah.
Of course, if it is an acute emergency, and if it is necessary to save life of patient, you are free. Without consent also you can switch over. So rightly said, in the case of Samira Kohli, in Samira Kohli, the same thing happened. He was actually for diagnostic laparoscopy. And he was case of infertility. As such, not infertility, rather, she had
endometriosis,
fibroids and endometriosis, and she was for diagnostic laparoscopy. And during diagnostic laparoscopy, there was profuse bleeding for any reason, and ultimately hysterectomy was done. She was still unmarried, just engagement was only happened, and case was filed. But in court of law, in Supreme Court, inference held by court was hysterectomy was not an issue because it was life-saving. And thank goes to Dr. Sudha Salan. She had been called in Supreme Court as an expert witness, and she gave her expert opinion that in this type of given situation, any gynecologist would prefer to go for hysterectomy. So that way, hysterectomy was not an issue in that case. But again, one more question was asked in Supreme Court. still doctor can be held liable? Yes. For what? Assault and battery under Indian Penal Code section 340 for doing hysterectomy without consent. So without consent, what then issue? Of course, compensation was demanded 25 lakhs, but compensation awarded only 25,000. So court didn't consider hysterectomy to be serious one, but court took serious note that it was without consent. So consent is very much important in any surgery and in our hysterectomy part also.
But sir, if it is a life-threatening condition, we can go without consent also. No?
Yes. I just mentioned. And as far as change of route also, if it is like, say for example, you started with vagina and there is some problem with uterine artery at the time of clamping, and you may have to go for laparotomy. And then you will naturally finish your hysterectomy by abdominal route, or you may go for endoscopic route also. So in this type of situation, you are free to go. But if you have counseled patient well in advance and consent has been given for the same, then you are totally free of any medical legal problems.
Thank you, Dr. N.C. Patel. And now I'd like to ask our panelists, what are the factors that affect the type of hysterectomy, starting from history? Dr. Shailaja.
Yeah.
How history will help us or guide us in deciding the type?
Yeah. History will decide definitely about the type of the hysterectomy. The main thing is the patient's age and how the patients have complaint like pain in abdomen, menorrhagia, as well as past history of any surgical history, laparotomy or endometriosis, dysmenorrhea, severe pelvic pain, past history of abdominal cocks, or past history of any laparotomy or major surgery or lump in abdomen. And patient may complain about passing something coming out per vaginum, and this all the things and previous history of the cesarean section, all this will give us the route of idea about how to operate by the abdominal route, by the vaginal route, or by laparoscopy.
Right. So so there is a definite role of history. Instead of directly examining patient, or instead of thinking a particular route well in advance, or instead of directly examining patient with sonography, this history of especially lump, dysmenorrhea, why we are doing hysterectomy, collapse, previous surgeries, even something suggestive of malignancy, that will help us in deciding the route. Now, Dr. Brijesh, how our clinical examination, especially medical conditions, will help us in deciding the route?
Definitely, sir. Medical condition, especially if she is very obese, nulliparous, or any huge pelvic mass, or any previous surgeries with there may be possibility of severe adhesions, may decide route of the surgery.
Suppose she is a very poor, high risk for anesthesia with cardiorespiratory compromise, and her lithotomy position with head low position and pneumoperitoneum can create a problem. So that might go against laparoscopy.
No.
So you have to assess everything. Yeah.
I will go for that. I will go for a vaginal hysterectomy then.
Depending upon all these conditions, your decision should be influenced. Suppose patient is very, very obese. Once I did a surgery for a patient whose weight was 130 kg. And when I examined her uterus, I was able to remove uterus very easily vaginally. So I was also surprised how this can happen. So it depends upon what are the medical conditions which are affecting. But obviously, Dr. Arjav, how clinical examination, especially pelvic examination, per-abdominal and per-specular examination, will help us in deciding the type of hysterectomy?
Yes, sir. When you examine the patient per vaginally and per abdominally, you can feel the lumps like irregularities in the uterus and big size fibroids, any other para the mass in the ovary or any previous surgery. We can see the scars, and that can help us to decide the type of surgery, whether we like to attempt the laparoscopy or we like to go for the laparotomy. Importantly, the cervix is also very important when you are doing PV and per speculum examination, whether you are seeing the mass in the cervix and you are doing hysterectomy for any suspected cancer. So, whom would you like to involve in the surgery, and all that entire thing depends upon the per speculum per vaginal examination. Importantly, the mobility of the uterus is also important in case of endometriosis or in case of cancer or in case of big mass, adnexal mass or ovarian mass. So yeah, per vaginal, per speculum examination, per abdominal examination definitely would guide us for deciding the route of the hysterectomy and our management path.
Dr. Chintan, please take over.
Yes, sir. So just to summarize regarding how would you determine the best route of hysterectomy, we have some patient factors like parity, general condition, nature of the disease, previous surgeries, and size of the uterus, as well as the size of the vagina. The surgeon factors are skill of the surgeon for particular route, the OT setup, which is very important, instrument availability and availability of anesthetists and gases, because we sometimes come across that in small centers, sometimes we don't have the anesthetists properly available or gases available, then the laparoscopic hysterectomy would be a problem. And there are practical points like patient's absolute preferences and the financial aspect too. Now moving towards the next question. So the success depends on all this criteria, and the important point is, in this era of sonography, we must assess every patient, by per vaginal and per speculum examination to assess the nature of the disease and the feasibility of a particular route for surgery. Fine. Now moving towards the next question. May I have the next slide, please?
Before you go ahead, Chintanmay, I just want to add that each and every patient, we need to do a per speculum examination and take a pap smear, and if it is better to do a DNC beforehand so that we can have the idea, because many a times when the uterus is then sent for the histopathology, there is a malignancy or pre-malignant condition. So it's always better to see, do the per speculum examination, which is sometimes, some of them, they just don't take the pap smear. So it's better to take, go stepwise in the examination as well.
Truly, ma'am, it's a very valid point. Assessment of cervix and assessment of endometrium is very important. Though sometimes patients may also force us that, okay, sir, so we have to explain them and counsel them that how important and why it is important. So that's how.
Dr. I agree with you completely, because if we do not put speculum, we might miss cystosis. We might miss even first degree prolapse, which may later on end up in valve prolapse. We might miss even some enterocyte. So all these factors, they change the route on time, which they influence the type of hysterectomy. So clinical exam, there is no alternative to clinical examination. You can see the rugosity of the vagina, you can see obliterated fornices, you can take a decision, you can see how lateral space is available, especially for a postmenopausal patient. So the clinical examination has no alternative. Yes, Dr. Chintan.
Okay, sir, may I go for that quick answer round? Your choice of route in particular conditions?
Yeah.
Okay. May I take the individual panelist for their answer? I'm sorry, this is not written in the slides. You'll have to just listen to me and answer. Starting with Rajal ma'am. Ma'am, we are just asking you a rapid fire, like, your choice of route of operation in this particular condition. Previous 2 or more LSCs.
If I have to, if I have to
Yes,
do,
ma'am,
then I may
you
go
are the
for
decision.
vaginal hysterectomy, NDVH. But then if I have to teach my residents about abdominal hysterectomy, then because I am in a teaching hospital, I may go for the abdominal as well.
Yes, yes, ma'am. I'm coming to that part also regarding abdominal hysterectomy to you only, since you are a professor. Next question would be for Dr. Brijesh. If the patient is nulliparous,
Yes.
it's a routine pathology. Your choice of route.
Laparoscopic hysterectomy.
Fine. Next, Dr. Akash, prolapse uterus.
Okay. Prolapse uterus with?
It's a prolapse. The pathology is prolapse.
Okay. If it is prolapse with cystocele and rectocele, then vaginal hysterectomy. But if it is just second degree descent or mild cystocele, we can go for laparoscopy, and then we can repair cystocele by vaginal route also.
Okay, so non-prolapse uterus with cystocele, you will go laparoscopically, right? With cystocele,
Yeah.
with the anterior repair.
Yeah, we can go for laparoscopy and vaginal both also, depending upon.
No, I'm just asking you your choice. Okay, fine.
Laparoscopy.
We are not generalizing right now.
Okay.
Okay, fine. Next to Dr. Ajav, suspected endometriosis.
Suspected endometriosis, I would prefer laparoscopy. And then if needed, we can always take, with prior consent, we can go for abdominal hysterectomy if needed.
Fine. Next to Dr. Sejal Ben, big uterus, more than 14 weeks size, ma'am.
Always laparoscopy.
Fine. I expected that answer.
Madam, I have, is it displayed? Can you see the screen? I have made some changes, Dr. Chintan.
Yes, sir. Yes, sir.
Suspected endometriosis, but uterus is free.
Okay.
And severe endometriosis, where you can't move uterus even slightly. So both the conditions may differ.
Right, sir.
Yeah. And large, how large? 14 weeks, 20 weeks, 28
yeah, it was more than 14 weeks.
Here, like up to 2 weeks, experts can do laparoscopic hysterectomy easily. Beyond like up to the Xiphi sternum, one has to justify the duration of surgery, the duration of anesthesia required for laparoscopic hysterectomy, and the removal of this the big mass with the vaginal morcellation or the vaginal morcellation compared to the big scar, vertical scar. So if considering the recovery, would like definitely for laparoscopy. Like post-operative recovery is very good for laparoscopy. So patients little young and strong and healthy definitely can go for laparoscopic route. But if patient has like other comorbid condition, cannot tolerate longer hours of anesthesia, little aged patient, in such a case, better to open so that the intraoperative events are eventful. Like
so either laparoscopic or an abdominal route, but not a vaginal route, right?
Okay. No, I would never.
Right. Dr. Shailja ma'am, with a patient with a morbid obesity, say more than 100 kg.
I would go.
Morbidly obese patient, if uterus is normal, then I will like to go for vaginal hysterectomy, and if uterus is I think large, then definitely I would prefer the laparoscopic hysterectomy.
How large?
So as
how large you said? How much large?
Many a time 18 weeks, 20 weeks we have done it, because in morbidly obese patient there is chances of compression of diaphragm, everything in when you are using the carbon dioxide, but we are doing it by extraperitoneal laparolift technique without using carbon dioxide, just lifting the abdominal wall, and we have done it in 120 kg female also.
Right, ma'am. So according to you, if the patient is morbidly obese, as long as you can manage vaginally, you would prefer that as a safe anesthesia.
In laparoscopy, in obesity,
we are
Yes, sir.
using extrapattern leprolift technique, so we are not using even general anesthesia. We are doing it under spinal anesthesia.
Yes, ma'am. We have seen your techniques and your videos, and we highly appreciate that.
That is not the issue. The issue is morbid patients are having other illnesses also at the same time. So first of all, we have to evaluate that patient, her cardiorespiratory status. She might be diabetic, and she might be a very bad condition in lithotomy position, as well as her diastolic dysfunction may be there, which may be precipitated during surgery. So we have to consider this thing, because I have seen obese patients who are being operated, they develop very severe hypoxia during surgery, even though your SS are very well. But they develop because of the abdomen is not moving at all, and because the respiration is compromised. So we have to keep this factor in mind.
I think I want to ask one thing. For a morbidly obese patient, we always go for, it is a routine that we always have physician reference, as well as in morbidly obese patient, we go for the echocardiography also, and then only we go for the surgery.
Shailaja, even though everything is fine, her cardiorespiratory status is also normal, but I have seen that these patients, they behave very badly under general anesthesia. Let me tell you. And there is another route. There is one.
That is what I am telling, sir.
Please.
I want to say only one thing. We are not doing it under general anesthesia. We are doing even laparoscopy without using carbon dioxide, without using this in spinal anesthesia. So this spinal anesthesia is very for regional anesthesia.
I want to add something, sir. In laparoscopy, in morbid obese patient, apart from these medical factors, the surgical factors are the obesity itself is a difficulty in surgery for pneumoperitoneum creation. When we create the pneumoperitoneum, the layers of fat interfere with our procedure and make it difficult. The initial part is difficult. There are chances of false peritoneum. The half length of the trocar is in the abdominal wall. So the trocar movement and instrument movement will be restricted if we have not inserted trocar obliquely.
We need a bariatric trocar, dear. We need bariatric varies and long instrument bariatric and can safely be taken with a workstation, and one can give the.
But if you can remove this uterus vaginally within 20 minutes, and if it is very easy to do, why to expose the patient to so many things? The thing is, it depends upon the skill, experience, team, and your workup, as well as along with the patient's morbid conditions and size of the uterus, mobility, everything. So many things are there which are to be taken into consideration. Okay.
Analysis will be difficult.
So it is an individual decision which you can take. Now moving to the next. So in which conditions, Dr. Rajal madam, where we cannot do vaginal hysterectomy?
As rightly said by Sejalban, very large uterus and then a very large fibroid extending up to xiphisternum, then it is very difficult to remove vaginally. So I wouldn't go for that for the vaginal hysterectomy. And of course, the patient's condition, if she's fit, because in olden days, like I have seen my madam doing left foot when patient is very moribund, then they just do the left foot operation and then close the whole.
So it is the size of the uterus,
as well as adhesion.
Yeah, adhesions, previous surgeries.
Previous surgery, vesicovaginal fistula repair or rectovaginal fistula repair.
Malignancy.
Inaccessible.
Malignancy along with the large ovarian mass also, we just don't go for the vagina.
Okay. And difficult lithotomy position, say for example, patient has something wrong with her hip joint, where you cannot give lithotomy. Fine. But do you agree with me that with experience, you can convert some of the difficult situations into easier conditions where contraindication can be converted into indication?
Not always.
Dr. Sejal.
Yes, but not always.
Yes.
Yeah.
You have to take that global consent that the route might change.
Yeah.
Even with
but
your expertise.
experience will tell you two things.
Yeah.
First, it will help in taking the decision well in advance. કે નહીં આ તો વજાઇનલ કેન્ડિડેટ જ નથી. આ તો આ પેશન્ટ આમાં નહીં કરવાનું. But that experience will tell you from very beginning. And second thing, experience will tell you how to manage difficulty at various stages. Say, for example, it's a large uterus, it's a fibroid, you know from where it is, how will you remove, you are going to plan the surgery. So it can convert a relative contraindication into an indication.
Sir, it's like the list of contraindication will get smaller and smaller as your skill for a particular surgery improves. So, I mean, I totally agree that for vaginal surgeons like you, the list of contraindications for vaginal hysterectomy should be a bare minimum.
One more thing, that nulliparous, as we said last time, but there is a series of cases, Dr. Shirish said, where he has performed vaginal hysterectomy in mentally retarded nulliparous girls. So nulliparity is not a contraindication. Say first degree descent is not required. The moment you apply your clamps on uterosacral, uterus has to move down. That is one. And the most important thing is pull and pull. That is required during the whole surgery. If you go on pulling, you will be able to see where you can apply the clamps or vessel sealer. Large uterus, okay, fine, or an average size gynecologist, 14 to 16 weeks is okay. Previous surgery is not a contraindication. You can do it provided you are in the proper plane. And the most important thing is any digging or any try to find out, open the pouches, and if you can't open pouches, then surgeon will be restless. That is not proper. Don't try to open the pouch. Pouches will open on its own. So that is not an issue. But at the same time, oophorectomy is also possible. What I would like to highlight is these are the concepts. Sometimes they require to be changed. There is no prolapse, vaginal is not possible. There is previous seizure, vaginal is not possible. So these concepts need to be changed. So success depends upon perfect knowledge of anatomy, and examination under anesthesia even may help you to change the route at that time also, because here you are exactly able to assess the mobility and stretching the cervix downwards, and you know how much descent you can achieve. This is very simple, but size of the uterus. Dr. Arjav?
Yes, sir. Yes, sir.
Yeah. So I have put a list where the size of the uterus is compared with the success rate. More the size, obviously, success rate is decreasing. But for an average gynecologist, I think size is 12 weeks is fine. 12 weeks uterus, anybody can remove it vaginally. It's very simple.
Yes, sir.
Fibroids are no more contraindications. You must map out the plan of your surgery, how you are going to operate, how you are going to remove this particular fibroid. You may morcellate, you may remove it, and then it will decrease the size of the uterus and will be easily accessible. So these are the things, some of the points, good instruments and good assistance. That is most important in both the things, in laparoscopy as well as in vaginal. So this is the recommendation. Dr. Chintan, please take.
Yes, sir. So after, going for all the indications and the preference of route, I would just like to acknowledge that, the international faculty still believes that, whenever it is feasible and it is possible to do the vaginal hysterectomy is superior to all, since it gives no scar, and there are multiple factors like less cost, less learning curve, and the recovery is also fine. So this is what international guidelines, the ACOG guidelines says, that whenever possible, and if you are comfortable with all the hysterectomies in a given case, vaginal hysterectomy should be preferred. I mean, people with excellent laparoscopic skills may prefer to disagree on this point, but yeah, that's how the international consensus goes. Just quickly, I just for the sake of a society, not an individual basis, I have 2 or 3 questions. First one is for Dr. Rajal ma'am. Ma'am, in this glory of laparoscopy, every youngster coming out from the medical college wants to do a laparoscopic hysterectomy. Is abdominal hysterectomy still relevant in the present scenario, and should it be taught in medical colleges?
Absolutely. Absolutely, I agree that abdominal hysterectomy must be learned, because only then and then you can achieve your goal for the laparoscopic surgery, because all these laparoscopic surgeons that are present today, they have learned their first skill as an abdominal hysterectomy. So they have to know the basics of abdominal hysterectomy. For me, that my student need to learn that abdominal hysterectomy, then they can go for abdominal. I mean,
fully agree, ma'am. Any laparoscopy surgeon has to be a good open surgeon. I mean, open surgery wise, I fully agree.
And whenever there is a complication in laparoscopy, they have to open it up, and then at that time, if they don't know how to,
perfectly,
then it can create lots of problems.
Yes,
you need to call abdominal surgeon then.
Rajat, totally agree with
totally agree.
Before the laparoscopic attempt, but laparoscopy has other more advantages, not only for the hysterectomy, but laparoscopy also everyone should learn for like other cases apart from the hysterectomy.
No, that's fully agreed.
That is agreed. Like
right now we are just focusing on hysterectomy. That's why I'm asking for the route. We do understand the laparoscopy has the empire of other surgeries. I fully agree. The second question is to Dr. Sejal ma'am only. Ma'am, do you believe that should a laparoscopic surgeon be skilled enough in a vaginal surgery too?
Yes, of course. We are students and we need to learn each surgical steps. ऐसा नहीं चलेगा कि आपको एक आता है एक नहीं आता है. Okay, your forte will be selective, either laparoscopy or vaginal, but one has to know the basic steps and anatomy for each route.
I fully agree.
So both
because
are,
sometimes larger uterus removed laparoscopically, they have to be morcellated vaginally, and so you have to be equally efficient in vaginal.
Repair cystoscopy, we have to repair enteroceal. Sometimes we have to morcellate from the vaginal end, and sometimes we have to end up with a supracervical hysterectomy, or sometimes paxis we do with neovaginal relation we do with vaginal and SUS where we do. So this we need to know the proper anatomy through the
True. So that's an important message for our young colleagues that no matter however you learn the laparoscopy and everything, but you have to be equally good enough in doing vaginal surgeries also.
I just want to add that you cannot become MD or MS unless you pass an MBBS. So you have to become MBBS, then and then you can go for either MD or MSD.
That's a perfect answer, ma'am. Ma'am, my last question, sir, I'm sorry, I'm just taking too long. To Dr. Gajar, sir, to Dr. Rajan. Yeah, Dr. Akash.
I want to add that the most important skill during vaginal hysterectomy is knot tying. When we are tying the knot deep into the cavity, when ligaments are stretched, this is the most important skill to be learned during for vaginal hysterectomy. Otherwise, there will be complication like hemoperitoneum and all this.
And learning to work in a less space also.
Nowadays, we are using a short version of laparoscopic shear. That is very helpful in vaginal hysterectomy also. So there is no need to tie and cut in a small cavity. You can use this sealer and cutter at the same time, the shorter version of the laparoscopic shearer.
Even ligature has
I would like
but
to
if
add
the pedicle which is sealed by ligature again bleeds, then we have to again knife. Then this is the basic skill that should be learned. So whenever
I fully agree.
Whenever we need to tie.
My last question would be to Dr. Gajar sir, Dr. Sejal Ben, since Sejal Ben have been recently elected in executive committee member in IAG, and to Dr. Rajal ma'am also. Isn't it that the time has arrived where we should have some accreditation system, like it's like everybody wants to do laparoscopy, right? But without taking a proper training and without acquiring proper skill, they just start doing it, and then the complication happens, and then this complication go in the name of particular route that, okay, laparoscopic hysterectomy has this complications. Now we don't have, we don't have a comparison system that who is doing it, and and that's how this inferences are wrong. So do you think that a person should be considered qualified in doing a laparoscopic surgery after having some test or some accreditation system? Same way it could be like a vaginal hysterectomy, like a vaginal surgery.
For it's a little longer compared to the open surgery, because this 3-dimension to 2-dimension orientation is like, it takes some time. So, the few courses are 4 days laparoscopy fellowship programs. So one can learn in 4 days a laparoscopy. You need 40 hours minimum on lapro trainer to learn the to get that orientation. Then another milestone is to achieve is the suturing. Endo suturing is another challenge. So I would say no one can learn in such a short course. And the proper, if you want to if you really want to cut short your learning curve, and that maximum complication occurs during that learning curve, you want to reduce your complication rate, then definitely you have to be dedicated 6 months, 1 year training program in laparoscopy. So that starts with the basic hysteroscopy to advanced operative hysteroscopy and operative laparoscopy.
Fully agree, and we must have some assessment system that who can do laparoscopic surgery better by Foxy or any other body. Over to you, Gajay sir.
Hello.
IAG is coming
Doctor said,
various certification courses this year. So we have planned many hysteroscopic basic and advanced, and many laparoscopic basic and advanced courses, where in simulators and animal labs, and we are giving them hands-on. So I would recommend new PG students or newcomers to join those courses and get oneself shorten the learning curve.
Dr. Sejal. Hello.
Yes, sir. Yes,
hello.
Sir. Yes.
The commonest problem which I have seen with the youngsters with laparoscopy is either injury to the bowel and ureter, because these situations they can lead to litigation. Now, how to prevent it or how to identify it earlier? The most important thing is that we do not discharge, we discharge them. There is, some sort of race of discharging them 1 day, daycare, surgery, all these things are there, agreed. But that is in the expert heads. The most important thing is after a laparoscopy, see, patient has pain also, patient has some tendernesses also. If you send this patient for X-ray, there might be gas under the diaphragm also, there might be some sort of carding also, patient might be vomiting, even under the effect of general anesthesia, and all these things, they mask the signs of colonic injury. So one has to keep in mind that, this is a difficult surgery and I am suspecting this, and if it is there, you should keep this patient under observation, because colonic surgery diagnosed late can end up in a major problem. Similarly, while we are using this cautery, we have to be careful about its use, its limitations, and we have to be well versed about it, at what distance from the ureter, or what current we should apply on uterine. So all these things, they require a long learning curve. It's not that within 7 days, 10 days course, one will learn laparoscopy. What do you say, Dr. Sejal?
Now with upgradation, many are safer modes of cauteries and all that are available. No instrument is safe. Safety lies on the surgeon hand. So even knife can cut aorta, right? So nothing is safe. On the hands of surgeon. So I would say whenever you are in doubt, detect it and confirm it intraoperatively only, and try to deal it with intraoperatively only. So if it is a bladder, can do cystoscopy or can the methylene blue dye test, or if it is a bowel, can do air tests under the water test, or can call the experts and get it checked, like call GI surgeon or call pro surgeon and get them check, and then only finish off the case, and do not leave the case under doubt. So after that, even
so again, preoperative assessment, say for example, severe endometriosis, broad ligament fibroid, even some sort of severe adhesions, even rectum adherent posteriorly. So these are the cases who should be prepared well prior to surgery, and you should call persons who are involved, or you may need the help well in advance rather than searching for another colleague at a wrong time.
Simple cases in the beginning years.
Yeah, fine.
Yeah, then you slow and steadily we can progress to the challenging cases.
So now our aim is to reduce the incidence of abdominal hysterectomy. Laparoscopy is not an alternative to vaginal. Now both the surgeries are coming under the heading of minimally invasive approach. And here vaginal and laparoscopy are minimally invasive approaches. And there are only two distinct advantages of vaginal hysterectomy, and there is a shorter operating time and it is more cost effective. And here you require a large team. So this is a comparison. Vaginal, laparoscopy, both have a shorter hospital stay, returning to normal activity faster in both. Functional capacity is better with both. Complication rate, if you look at vaginal, more chances of injury to the bladder. In abdominal, ureteric injury is still more common. Forgotten mop, hernia, wound infection, dressing problem, postoperative adhesion, so many things are more with abdominal. And minor complication rate with laparoscopy is less. But if a surgeon is not experienced, major complications can occur. And we have to counsel patients well in advance about this. And Dr. Mane, you will agree with me that there is a different consent for laparoscopic hysterectomy in your FOXI guidelines, because it differs from other types of hysterectomies. Okay.
Right.
Patient satisfaction is both depending upon patient's nearby neighbor has undergone a particular surgery and will tell her that tare jaine kehવાનું ke mare laser થી જ કરાવવાનું છે, અને કાતો because but one thing is sure, patient satisfaction is better in both the routes. Operating time in vaginal is definitely shorter and cost is lower. Febrile episodes are higher with abdominal. Limitations, there are limitations of vaginal where you cannot do vaginally. You have to resort to either laparoscopy or in some conditions in abdominal. Attempting a fibroid at a level of xiphisternum by morcellation and all these things in a routine average private setup is very risky. It is better to go to abdominal in that case, because for patient route may matter to some extent, but safety matters much more. So for a beginner or a person with limitations or a person where other help is not possible, we have to consider all these factors in deciding the route. Don't be shy about going for abdominal if you think that this is not possible. Dr. Rajalben, what do you say? Agree?
Agree, sir.
Yeah. So there is nothing wrong in accepting that I am not able to do this surgery by this route, instead of showing heroism and attempting it and then ending up in a problem. So for patient safety matters much more rather than anything else. So some of the cases. Yes, Dr. Brijesh. You can see a fibroid there in the center of the uterus. Uterus is uniformly enlarged. Adenomyosis fringes are also there. It's a large uterus, pelvic, menorrhagia, patient is having, and dysmenorrhea also. Which route will you advise?
I will prefer laparoscopy, sir. Total laparoscopic hysterectomy.
Doctor, this will be removed within 20 minutes. You just open the posterior pouch, retract the bladder, and then vessel sealer, uterine arteries are being taken care, and just you pull the fibroid and then uterus will come out.
Definitely, sir.
Yeah. Okay, fine. So,
sir, in that case, uterus was uniformly enlarged. So when we do NDVH, if uniformly enlarged uterus may not descend very well. So if uterus is eccentrically enlarged, then with larger fibroid, even the vaginal hysterectomy will be easy.
Yeah, we can bisect the uterus.
Bisect, yeah.
We can bisect the uterus and then it is very easy.
Bisect, but for
or you can enucleate the fibroid also and you can remove, and otherwise you can bisect. If it is not fibroid and it's an adenoid, you can bisect the uterus. So once you bisect, you can apply the fundal, corneal clamps very easily.
Yeah. So either bisect, morcellate, or you can cut the uterus, keeping
Central
a large
coring.
mass laterally.
You can
large
go
mass
for coring or ribbon method.
Yeah,
also.
coring. Fine.
Ribbon
fine.
method is also very safe. Even we can do up to 18 to 20 weeks of uterus without damaging the intestine or anything.
This one, Dr. Arjav or Pranay can also take.
Laparoscopy route I would prefer. Would like to separate the fibroid and then go for hysterectomy, and then you can do vaginal morcellation or abdominal morcellation, whatever you are comfortable with.
Just tell me, Dr. Sejal, which specific difficulties you are going to face in this patient in laparoscopy?
This fibroid uterus.
Yeah, these fibroids, very small uterus. Do you find this as a routine case or something? This patient may require some expert surgeon.
If it is like palpable uterus for abdominally, I would go primary trocar above the level of umbilicus, and
fine.
And after that, I don't think if the primary artery is like okay, we have good visibility, then only the like if mobility is not there, then only we'll have a problem. So here we make
15 centimeter, almost 18 weeks, 18 weeks size uterus.
Will go above the 10 centimeter above the height of the fundus. We'll go the primary trocar. Need a 30-degree telescope here to visualize all both sides, and we need vaginal manipulation and simultaneously maybe the myoma screw spiral to get the better visibility. So
yeah, you will need myoma screw because vaginal manipulations will not be able to go to such large uterus so effectively.
Sir, it depends. Right? If fibroid is the fundus, then you may be good enough get visualization. But if it is on lateral side, it will be very difficult if the fibroid is on lateral wall.
I think because the fibroid is very big, it is many a time it is difficult to reach up to the pedicles and many a time the uterine vessels because of this big fibroid that is sitting on the fundus. So in those cases, we prefer to first remove the fibroid. If we are doing by laparoscopy, then we remove the fibroid and then go for the hysterectomy, and then we remove everything.
Here uterus,
so
uterus and fibroid are, sir, different. Sometimes whole uterus is converted into a big mass. So in that case, the difficulty is trocar placement. Here uterus is almost normal or bulky size and extra fibroid is there. So we can do it with normal trocar placement or slightly above than normal. And we can apply screw or traction in uterus also, or even slightly lower side in the fibroid also. So hysterectomy here will be easy. And the difficulty is only morcellation.
Yeah. So see, I would like to highlight how this technology has helped us. This case is before 30 years when I started doing vaginal hysterectomy in this patient. I was able to reach up to the fibroid, and then fibroid got separated and went into abdomen. Now, Dr. Sejal, I could remove uterus vaginally. Fibroid was moving in the abdomen. It was not coming within my grip.
Then you definitely need one laparoscopic help to push the fibroid of vaginal wall.
Yeah.
And this does happen sometimes after a total laparoscopic hysterectomy also. While morcellating from vagina, just uterine wall gets out and the fibroid inoculate and remains inside. कितनी बार पेशेंट भी सर पेशेंट आप लेप्रोस्कोपी करोगे तो अंदर कुछ छूट नहीं जाएगा ना.
Now this one.
Yeah.
Previous cesarean section. Patient has menorrhagia, bulky uterus, 10 weeks, and there is bowel adhesions near umbilicus.
Sir, how do you diagnose bowel adhesion near umbilicus?
I'm coming to that. I am showing you the intraoperative picture. So you have to think that whether there is adhesion or not. And that is why if you put trocar through umbilicus, you know what can happen.
So sir, it is not
we don't
necessary.
diagnose, we suspect it.
Yeah, it is not necessary always to introduce the primary trocar through the umbilicus. We can change that position we can enter from the secondary trocar sites, and then we first see whether there is any adhesion or not, and then if there is any adhesion, then we can remove it laparoscopically also. But this is if it is 10 to 12 weeks, then you can do it vaginally also.
Vaginally also, yes.
Fine. And now this adhesion is existing since years. So do we require it to get excised through the laparoscope, or patient doesn't have anything, any pain? So many times adhesions are there and they are there for years. So it doesn't matter. But how do you think that this patient is adhesion? When you are examining this patient,
lifting the abdominal wall, lifting the abdominal wall, patient will have a pain or catch in breathing and severe pain.
Yeah, so that can stretching the adhesions or bowel.
With umbilical hernia also. And because there
so again, you may need to repair umbilical hernia at the same time, but that is not repaired through laparoscopy. Anybody?
The operative field, then only if they don't come between our operative field, or we don't need to remove.
Okay. Now this one, nothing with the uterus. Adhesions are there. Vaginally, uterus is mobile, freely mobile. These adhesions are already there. Anyone?
Size of uterus?
Size of 10 weeks.
Okay.
Vaginally, you can remove.
You can do it vaginally.
No previous surgery.
Vaginal route.
Okay, fine. Oh, diphisternum. We have already discussed this.
Diphisternum.
Up to removing so many fibroids, I think it is better to go for abdominal in our setup.
Abdominal. We'll prefer abdominal.
Yeah. Now this one. I open abdomen. I could not find out 1 centimeter area of the uterus which was bare without any bowel, omentum. Oh yeah, frozen pelvis. Which route?
Abdominal.
Abdominal or laparoscopic?
Laparoscopy will be risky here.
But sir, that will depend on the skill of the surgeon. Na?
Laparoscopic.
Sometimes, the laparoscopic surgeon will see better laparoscopically than abdominally.
Correct, sir.
Patient has Cox abdomen, there is nothing wrong with the uterus. Why do you want to remove uterus?
Laparoscopy would be give a view, a larger view, enlarged view, and precise cut. So for me, I would definitely very comfortable laparoscopically, even in frozen pelvis.
Madam, there is nothing wrong with the uterus. Why are you going to do hysterectomy? Because this can end up in anything. So we should know where to stop. We should know when not to do. Nothing wrong with the uterus. No complaint.
Then why the laparoscopy was done?
That is why I am telling you.
Why then laparoscopy was done when patient has no complaint then?
Yeah, that is the
no complaint.
Are in the habit. Some people are in the habit of diagnosing erosion and asking for hysterectomy. So inadvertent or unnecessary hysterectomy can create many problems.
Yes.
Okay, fine. Now, Chitta, it is up to your turn. Your slides.
Okay, fine. Fine. This was a picture in laparoscopy, but I mean, such a case, I would just again ask the panelists what way you would prefer. Though I had taken this for laparoscopy, but would this be a good case for vaginal? Anyone can come.
I think in this
what is the bowel is adherent to abdominal.
This is the bowel.
I think it's
bowel is adherent to the posterior wall. Yeah.
Okay, and the picture is of laparoscopy, and the instrument is energy source or scissor.
It's a shearer.
Okay.
See, forget about the instrument. I mean, this was a scenario. Would this be better vaginally? That's what I just wanted to ask.
No, laparoscopically.
Yeah.
Here, if we want to do vaginally, we can just look for adhesions, and we can do adhesiolysis by laparoscopy, and then we can go for vaginally also. If uterus is normal and other factors are favoring vaginal hysterectomy.
Okay, I would be rather, I mean, whether this additions would be manageable vaginally, I would still be in doubt. But yeah, okay, fine. A good vaginal surgeon might be able to deal with.
Hello. Many times it happens that cul-de-sac is obliterated and you are suspecting dense adhesions. But if you remain very close to the uterus and if you don't try to open the pouch, you just retract the rectum and remain close to the uterus and go on dissecting in the uterus, then there are no chances of injury to the bowel. And then at one stage, you will be able to open peritoneum at a higher level. This is possible.
But I mean, that is with a highly skilled vaginal surgeon, sir.
Laparoscopy
Not an average vaginal surgeon.
Laparoscopy will be preferred in this case.
Correct. Around 12 to 14 week size uterus.
Can go vaginally.
Yeah.
Right, ma'am.
You can go vaginally.
Again, severe bowel adhesions.
On the with the uterus.
Yeah.
Then we need to do it laparoscopically. We need to go for the adhesinolysis and then.
True. Again, big fibroid. This was a kind of eccentric fibroid with the uterus around 20 to 22 weeks.
Sir, this lateral wall distorted anatomy, we have to do first ureterolysis to avoid possible injury in lower pedicles to ureters. So first ureter should be identified and then we can go for routine hysterectomy. Or if it is true broad ligament fibroid, then there are also chances of ureteric injury. So the
okay, Akash, I mean, let me just clarify. This was a way away from the ureter. It was a uterine fibroid only, not a broad ligament fibroid. It was arising from posterolateral wall.
Yeah.
The just question is whether to go for vaginally or a laparoscopically.
Laparoscopically, I will do.
Laparoscopy. True. That's what
I think we have discussed this. Dr.
Yes, sir. This is done.
Yeah, all these things we have discussed. Now, Rajal madam.
I have already said you have to become MBBS first, then to become MD or MD.
So first teach them abdominal hysterectomy, then gradually make them expert in vaginal, and then gradually expose them to laparoscopy. Is it the proper way, or you like to change it?
No, it's.
Or you like to teach all of them at a time?
No, not at a time.
So because you are a great teacher, you know what to teach to a student at what time.
You have rightly said, sir, that first they have to learn the basic and then go for the advanced.
Yeah, madam. Yes.
बाद में सेजल मैन के पास जाने का है.
So ultimately, we have come to the conclusion that even in non-descent, moderately enlarged uterus, still vaginal hysterectomy is safer.
Yeah.
Morcellation can be done. There are many ways: coring, bisecting, morcellating, and even cutting the uterus, literally keeping a big mass, and then removing the uterus centrally, and then you just pick it up and then apply the clamp. So that it's not going to bleed a lot. So it's the experience, operative time, blood loss, complications, all are taken into consideration. Thank you very much.
Ma'am, days are going to soon where people need more of a vaginal surgical workshops and more of a vaginal surgical training course and vaginal delivery course rather than laparoscopy.
Yeah.
Yes, madam.
True.
But I have observed in my series of cases, 85 to 90% of hysterectomy can be performed vaginally safely. If you look at the indications, as in the first slide, as we saw, that 85% of the indications of hysterectomy are for benign conditions. And in these conditions, unless there are adhesions, unless there is a very large uterus, unless there are fibroids, it is such a particular conditions where it is difficult to do vaginal, then laparoscopy is an option to abdominal. It is not an option to vaginal. Thank you all, dear panelists, and Dr. Chintan, Dr. Rajan, and Dr. Sejal, Dr. Shailaja, Dr. Aditi, Dr. Brijesh, Dr. Arjav, for Dr. Akash and Dr. Pranay for your important inputs, very important inputs. Thank you very much.
Thank you all.
Thank you
My
very
last
much.
comment.
Thank you, sir.
My last comment that to particularly.
I want to add, sir, something. There is a, as you said, sir, 90% of hysterectomy can be done by vaginal route, and some of them can be done by abdominally also. So there is overlap between vaginal and abdominal. There are some absolute indication for vaginal, like third-degree prolapse. Coconut prolapse can be done vaginal route only, and there are very big uterus that can be done abdominally. So when we want to teach our youngsters, they should know vaginal hysterectomy, but when they have some cases for abdominal hysterectomy or by laparoscopy, at the same time, some vaginal surgeries can be converted to laparoscopy or abdominal route to teach them. Or some large uterus or difficult vaginal hysterectomy that are relative contraindication for vaginal must be rather than taking laparoscopy can be treated by vaginal also. So what we want to teach them is up to us. In our era, when we were in residency, there were no any video conferences or YouTube videos available. So right now, many videos are available. Almost every doctors are preparing their videos and posting on YouTube. So YouTube and other media are very good platform for learning, and everyone can learn easily. The simulators are also available. But in vaginal hysterectomy, what we see in conferences also, the photographer is also struggling in recording video. Some part is visible, or we can see only the back side of the surgeon many times. So it is always easy to teach laparoscopy, while vaginal hysterectomy requires some difficulty in teaching also.
It depends upon teacher. It depends upon
absolutely, sir.
So many things
That's
are
why
there.
we have done just for the knowledge. We have done a vaginal hysterectomy workshop at our my own hospital in Bharuch Obstetric and Gynec Society. I may send you the video if I have. But there's an excellent view with excellent demonstration of each and every step. Around 6 to 8 surgeries were performed. So I think that problem is manageable. I mean, if you want to teach, you can demonstrate and teach very well, even the vaginal procedures.
Chintan bhai, I would suggest that you can upload these videos on YouTube and share those links with so that it's
sure, ma'am. I'll have to check whether I have that videos, because it's a long time back, but I'll definitely do that. And my last comment is, don't we think that it's high time to which have come that we should teach our youngsters that please avoid unnecessary hysterectomies. There's a lot of it's a lot of burden on the society and healthcare system.
True.
Thank you, sir.
Yeah, thank you very much, all the panelists.
Thank you, Chintan.
Thank you.
Thank you.
Thank you so much, everyone. Excellent panel, excellent discussion. All the panelists and the moderators.
Thank you, ma'am, for giving this.
Yes, great. Chintan bhai and Gajjar sir, great moderation, and all the panelists. Everyone has given their whole part.
1 minute. I would like everybody. Just 1 minute. I would like you all. I would like to invite you all to ISAR SOG's annual conference at Surat on 9th and 10th of February. So please participate in large numbers.
When is it, ma'am?
And 10th April, no?
It is 9th and 10th April at Surat.
Okay, it's a physical conference.
Chapter along with SOG Surat Gynec Society.
It's a physical. It's an offline.
It's a physical.
Okay, fine.
Yeah. You'll receive the invitation soon. Thank you so much.
Sure, ma'am. Yeah.
Sejal madam, congratulations.
Thank you, sir. Thank you so much.
Where is the party? Because I'm your voter.
The party, sir. We'll tell
I'm your voter.
9th and 10th April at Surat.
Yeah.
It is in conference.
Yeah, great.
Surat conference માંથી સીધા બધા સેજલ મેમ ના ઘરે જવાનું છે.
Great.
Till then, I have changed my background so that you can have chocolates.
ये देखो ये मैडम पहले तैयारी में बैठे हुए.
Chocolates for all and Diwali, Holi and related greetings to all.
सर आपका मेरे जैसा छोटा पार्टी नहीं चलेगा, आपका बड़ा पार्टी चलेगा.
बड़ा पार्टी आप लोगों की सहायता से ऊपर गया तो बड़ा पार्टी दे दूंगा उधर आके 100%.
हम तो औरंगाबाद आएंगे ना सर.
हाँ औरंगाबाद आइए ना, औरंगाबाद 100%।
Yes, yes.
यहाँ बड़ा प्रोग्राम करते हैं
सर। आपका और राजल मैम का जीतना पक्का है।
आप लोग साथ में हो तो पक्का है सर।
बिल्कुल साथ में
ये
सर।
पक्का ही है ना, पक्का ही, तभी तो बोल
जी
दिया
जी।
कि पक्का है।
अरे वाह, क्या बात है, थैंक यू वेरी मच।
Thank you so much. And it was great meeting you all. This is the positive side effect of COVID कि we can meet through webinar.
ये बात सही है, ये बात
कुछ
सही
तो अच्छा
है।
हुआ है।
ब्लेस इन डिस्गाइज बोलते हैं उसको, उस टाइप में हुआ ये।
इट इज
चलिए,
लाइक कि
thank
जो
you.
मन
Great.
का हुआ वो तो अच्छा ही हुआ, जो मन का नहीं हुआ वो और भी अच्छा हुआ। कोविड वाज नॉट आवर मन का, but वो और भी अच्छा हुआ बिकॉज वो भगवान का किया हुआ।
सही है, we can reach to each and every corner of Foxy basically,
Yes,
which is physically not possible.
Yes.
And it saves lots of time and energy and money
Obviously.
of travel and going.
True.
Absolutely. When physical meeting is always good, but then at the same time,
We can go at least 3 or 4 places a week at the most. Every day we are going to 3-4 societies, no, through this meeting. It was popular in Europe and America before the COVID era, but now it has become popular in India also.
Yes.
Yes. Yeah.
Okay, sir. Thank you.
Bye-bye. Thank you.
Thank you. Bye.
Thank you so much. Thank you everyone.
Jagruti madam.
Thank you, Doctor.
Official vote of thanks. Official vote of thanks.
Yeah. You carry on, sir.
Shall I give that?
Yes.
Okay. Now we come to end of the great webinar, great panel discussion and 3 lectures. So I convey my gratitude to Surat OBGYN Society, particularly Jagruti madam, who has been instrumental after all the efforts. And thank you, madam. Thank you, Alpesh sir, MC sir, Gopal sir, and Meenakshi ma'am, and the great speakers, Abhat sir, Mohit sir, Pandit Palaskar sir, Garjar sir, and Chintan Thakkar sir, and the chairpersons, Jagruti madam herself, then Sheila Maure madam, Kajal Manguke ma'am, Keyur Padalia sir, then our great panelists, Akash sir, Arjav sir, then Aditi ma'am, Brajesh Patel sir, Prana sir, then Shailaja ma'am, our own Sejal Naik ma'am, and Rajal ma'am, and the MOC, Dr. Kavita Shah ma'am. I think nowadays sir has not joined. I was absent for 15-20 minutes, so unfortunately, okay, no problem. But and I'm most thankful to all the delegates who had been there at the quantity of 81 here, and I don't know, on the YouTube there must be 150 or 200 around. They are there with the on the auspicious day of Holi. In spite of having their puja and everything, they have attended is. Thank you very much, and thank you Jagruti madam again for conducting this. Thank you madam. Thank you very much.
Okay, thank you.
Yes.
Happy Holi.
Happy Holi. Happy Holi.
Happy Holi.
And unity is our strength basically. So I learned unity from Gujarat, and I always say that Ahmedabad and Aurangabad OBGYN Society are sister concern. Every time we conduct a conference, there are only 3 persons are permanent there. Alpesh Bhai, MC Patel sir, they both are we consider them as Aurangabad OBGYN Society members. And now Gajjar sir, sir you are muted. Gajjar sir, you are muted.
Has given great leaders.
Yes.
Leaders everywhere in Foxy or as well as in politics also. So
yes,
Gujarat
100% sir,
being the
100%.
state, it is ahead.
Yes, 100% sir, and we need this leadership of national level for next 10 to 15 years again.
Yes, and Dr.
नरेंद्र भाई,
is
आपका नाम उनका नाम साधर में है, पर वो हमको और कम से कम 15 साल चाहिए सर वहाँ सत्ता में.
Dr. Narendra Gajjar is the master and king of South Gujarat. You ask him any topic, he is always ready.
I am just a small person who will be immediately ready.
नहीं, ये नरेंद्र नाम में ही जादू है मैडम. नरेंद्र नाम में ही जादू है.
Sure.
You just tell me and I will say yes. That is the only thing that I can do.
Yes, great.
I remember the conference at Ahmedabad when he was present there for all the days. And from morning, I met him once in the morning, and in the evening when I again met him, he was requested to sit in the panel. So he told me, this is the 3rd panel I am attending today. I am sitting as a panelist. So any panel, any presentation, he is always ready.
Yes, it's great.
Dr.
Great.
Jagruti, it is really, it was a pleasure for me to attend the thing, attend academics, and really it's a pleasure for me to meet all of you.
It is rejuvenating, basically. Having academics is rejuvenating.
Yes.
Yeah.
So
And
thank
it
you.
is
Good night.
always-
Thank you very much.
It is always
Thank you.
very good to share your knowledge.
Yes, ma'am. Yes, ma'am.
We learn by sharing it.
Yes, 100%. Yes. So happy Holi to all of you. Happy Dhuli Vandan. We said Rangon ka त्यौहार है.
Ajay, one point I wanted to say, there
जी,
is
जी.
a beautiful book written by Atul Gawande on checklist manifesto. Beautiful book. He has written many books, all on medicine. And
I have read 2-3 books of him. This is not read.
Checklist manifesto. It's a very nice book.
Achha, that I'll find it out.
Yeah.
Yeah.
Okay.
He is personal physician to President of America.
Yeah.
Atul Gawande. Great persons.
Great person. Yes.
So thank you, madam. Thank you very much. Thank you, sir.
Yeah. Bye.
Bye, Rajal ma'am.
Bye.
Good night.
गुजराती में आवजो बोलते हैं, so आवजो का
आवजो
मतलब
बोलते हैं
है
ना? आवजो.
come back again.
Yes. आवजो. औरंगाबाद आवजो.
Aurangabad also. Yes. Okay.
Chalo, bye. Thank you, madam.
Thank you.
And bye, Chitrakala and Dr.
Thank
hello,
you,
Dr.
Stalin
Stalin, sir.
and Chitrakala. Yeah.
Thank you so much, sir. Thank you, ma'am.
Thank you.
Yeah.
Okay.